You're right here.
I thought we got this in the email, didn't we?
He wasn't in that committee. I don't sign out. I read it online.
Yeah, I'm sorry. We should have emailed it.
Okay, good afternoon, everyone. I'd like to call to order the Central Health Board of Managers meeting. Are we ready?
It's updated. I got you.
It is Wednesday, 20th, 2013, 5:37 p.m. The first item on our agenda is citizens' communications. Do we have any? There we go.
Needed the list.
All right. Good evening, Board. We have 4 speakers signed up tonight, and looking at the names, I believe all of them are well aware of our rules, so if it's okay with you, I'll suspend reading those and start with Mr. Jim Rodriguez.
Thank you.
Hello. Good to see all of you again. It's been a while. I just came tonight to kind of give you a brief update. In your packet, you should have something a little bit more detailed that you can take a look at your leisure. But basically, I just wanted to let you know that Tex Health Central Texas is alive and well. We did actually get our grant renewed for this biennium, but we've changed our mission. We're no longer going to cover people on a health plan. But what we are going to do is we're going to continue with our mission of trying to assist people to obtain health care coverage and to help them pay for that through a subsidy that we have available to us. So instead of us taking the risk, we're letting the insurers and the exchange insurers take the risk, and we're going to help the employees who can't afford it pay for it. So it's a very good model, I think. It falls right within the dictates of the Chapter 75, which we operate under. And that's in your packet too. You can take a look at that. But what we're basically going to do is we're going to provide 1/3 of the premium for an employee share of the premium. So, for example, if you have a premium of $300 for an employee, we'll pay 1/3, which is $100. And then the employer, who's required to pay half of the premium by the insurance contract, would pay $150. The employee would pay $50, and Tex Health would cover $100. So we'll pay up to $120, 1/3 of the premium, up to $120 for people who are eligible. That's in your packet. And the model that we've come up with is something new, and it's kind of exciting, and we're very anxious to roll it out. We have about I think 500 slots that are available. If you recall, Tex Health covered about 1,000 employees. We anticipate at least half of those will come back, and we think it's about 140 businesses. So we're starting to sign up folks now. We're getting lots of calls. We're rolling it out now. We're going to start out our first month with probably about 60 or 70 employees total, and then we'll keep signing them up after that. They will be required to show proof. They'll show us proof of their insurance contract. They'll show us proof of what the employee is paying. They'll show us proof that they paid their premiums, and we'll do that on a monthly basis so that we can verify and accumulate the data. We have set up a database specifically for that, and it will provide us the reports that we need, and we'll also provide reports for TDI that I think will satisfy their criteria. And that's basically what I'm here for, is to tell you we're still alive and well. And my last message is I want to thank all of you very much for your support. When Tex Health was winding down, it was a very trying time for all of us, including the employees. And I just really appreciate the support and help you gave us during that trying time. So thank you very much.
Thank you, Jim.
Thanks, Jim.
Thank you.
And our next speaker is Christy Garby.
Good evening, board members. Christy Garby, Vice President for Planning Communications. This evening, I will not get the beeper. I will be brief. That was just terrifying the other day. So tomorrow night we have an event, Transforming Healthcare in Central Texas, where we're going to report to the community on the transformations that have taken place and started since the passage of Proposition 1. And I'm up here tonight to just reemphasize our invitation to the entire community to come and participate. It's at the Palm Door at 401 Sabine Street, and we'll be also providing complimentary parking at the Convention and Visitors Bureau parking lot. Our featured speakers will be Rosie Mendoza, Senator Kirk Watson, and Dr. Mark Hernandez, the Chief Medical Officer for the Community Care Collaborative. So we sure hope to see everyone there. Thank you. It's at 5 p.m.
Thank you, Christy.
Our next speaker is Adam Schlossberg.
Hi, good evening, everybody. It's a pleasure to announce to you that DISH's Mental Health Substance Abuse has listed me as the only advanced peer support specialist in our state of Texas. It's not a pleasure to announce to you that they are mistaken and have left out many of my peers in the cold. It is shameful. It is also a pleasure to have been working on the Affordable Care Act and seeing the fruits of your funding result in positive forward movement. Very much led from my personal experience by Michelle, who is the utmost professional in so many aspects that defy her youth. That doesn't count. I'm tired.
Okay, we'll give you back 5 seconds.
So allow me to shift gears. What does a person with mental health issues need to do to be heard in the great state of Texas? For now 7 months and 1 day, I have battled the lack of care afforded to me through our local mental health authority and the eMERGE program. And I've had it from fairly reliable sources. I am not the only one, and hence the issue is in fact systemic. People with mental health issues do not want to complain against their providers of last resort, and most often will not, for a variety of reasons. You have before you someone that is in a fortunate circumstance to be able to do so. In yesterday's Community Care Collaborative board meeting, my stomach turned and twisted in frustration, anxiety, and fear for what is coming down the road on the mental health side. The commentaries I have from this perspective are far too long to express in this medium, yet rest assured my extreme apprehensiveness for my peers. You can only break a system of care so many times before the populace is disenfranchised. As I mentioned in my first communique, we must do better for our population. We must and we can. Please ensure the Community Care Collaborative does become not just a shining model of Texas, but more importantly, become a system of care that benefits its clients. You have a tremendous opportunity and responsibility. I provided a citizens communication for the Community Care Collaborative that took place yesterday. I give you that communication and this communication for your records. Again, I very much appreciate your time.
Thank you.
And our final speaker tonight is Mark Hernandez.
Board, audience, thanks for hearing me tonight. What I wanted to offer up to you, and really what I'd like to do is thank Adam, who preceded me up here at the lectern. So Adam, thank you. For bringing to the CCC board, and you've just been handed some paperwork so you can read his comments, bringing a concern back to the CCC. I am the chief medical officer. Somebody just said that that's who I was, Christy. I'm the chief medical officer of the Community Care Collaborative. What does that mean exactly? Well, what that means is that I'm the chief doctor for taking care of the uninsured and underinsured people in Travis County. Now, I may not be responsible directly for all of their care, but I am responsible for ensuring that the care that is provided inside of the safety net is of the highest quality, provides the highest patient satisfaction, and provides the best efficiency in terms of cost for the county. And as such, I'm very concerned anytime that we have failed to meet those standards for the care that's provided in Travis County. around the uninsured and underinsured. And so I appreciate the fact that Adam has been willing to come forward and speak about his experiences, even if they've been deficient, and to hold us to that and call us to task. And so I want to thank him for that, but I want to assure the board, but also the public and the folks that, you know, will hear this story later, I'm the responsible party. And I hold myself out to be the responsible party, and I wanted to say that out loud today at this meeting. Because I do think that at the end of the day, there has to be accountability. And I believe I'm the accountable party. I'm working to address any and all concerns that come up around quality of care issues inside any of our contracted service providers. And so I wanted to offer those comments to the board. I also wanted, on a perhaps more positive note, offer up to you that the Community Care Collaborative is an active organization. We are responsible for the care provided to the uninsured and underinsured today. We're actively working with our contracted service providers to see that that care is of high quality. It does provide high patient satisfaction. And we are beginning implementation of the various DSRIP projects and other pieces of the integrated delivery system that will, over time, transform the care for the individuals in Travis County for which we are responsible. And so I think that is a big event. We're going to talk about that more tomorrow night. But I wanted to be able to address the board with those comments because I think it represents a watershed moment for what we are doing in terms of care for the uninsured and underinsured in Travis County. Thank you very much.
Thank you. Okay. We're good? Thank you. Okay, on to our consent agenda. C1, approve minutes for the following meetings of the Central Health Board of Managers. A, August 29th, 2013 public hearing, and B, November 12th, 2013 special meeting. C2, receive the October 2013 investment report and ratify Central Health investments for October 2013. And C3, approve the adoption of a resolution regarding fund selections for the Travis County Healthcare District Retirement Plan with recommendations from Southwest Retirement Consultants and Branch Banking and Trust Company. Can I have a motion for the consent agenda?
I move that the board approve consent agenda items C1, C2, and C3.
I second it.
Thank you. All in favor signify by saying aye. Aye. Any opposed? Thank you very much. On to our regular agenda. First item is receive and discuss an update on Central Health's efforts related to Dove Springs and surrounding communities impacted by recent floods. And we have with us Mr. Larry Wallace and Michelle. Hi, Michelle.
Hi.
Hi, I'm Larry Wallace, and you know Michelle Tiarina. She's the navigation manager, and she's going to give an update on the activities that have occurred within our staff and that was sponsored by you, the board, to help provide support to the Dove Springs and surrounding communities as a result of the flooding situation. And also included in that is the work that's being done by the Latino Healthcare Forum, which you also sponsored as part of some of the on-the-ground efforts that come out of Central Health. So Michelle's going to give the report. Claudia is not here, so I'm sitting here with her. Not that she needs me, but I'm here.
Thank you, Larry. So as an overview to the board on the efforts conducted to assist families that were affected by the recent flood, internally, staff from Central Health, Eligibility Services, Community Care, and Sendero have all volunteered to assist with these efforts. Eligibility Services staff have assisted with intake, referrals, and application assistance at the Dove Springs Recreation Center. Sendero has provided over 100 care packs with towels and blankets and wipes, hand sanitizers, and gift cards for those affected as well. And Community Care is providing expedited financial screening and health care services for those in need. They've actually transitioned the medical care that was provided by the Red Cross over to the William Cannon Clinic. To date, they have seen over 24 victims that were directly affected by the flood. with their primary needs being more acute and to replace prescriptions that were lost during the flood. Externally in the community, Latino Healthcare Forum has taken the lead out in the community to continue ongoing efforts to assist those affected by the flood. They were one of the first organizations on site out in the community, and they volunteered to provide services of all kinds to those in need. And to this day, they continue to provide home visits, surveying each residence to meet their needs, coordinating their basic services for basic needs in healthcare, and they're working closely with community care to ensure that they all have a medical home to go to and to meet their medical needs. Lastly, we did have several employees that were directly affected by the flood as well. Eligibility Services conducted a fundraiser this weekend, and staff throughout the organization have been very generous and have provided donations in multiple ways. And so at this time, we would like to thank everyone, both internally and externally, for their generosity and for their ongoing support.
Any questions or comments? Yes, go ahead.
Ms. Tiarina, I'd like to ask what kind of coordination has there been with regard to addressing some of the trauma issues such as mental health or behavioral health care needs? Have we partnered or collaborated with anyone?
I know that Community Care has partnered with ATCIC, and I don't know the specifics of the patient care, but I know that they mentioned that they are providing the needs for mental and behavioral health services as well.
Thank you.
Brenda, if I could add one point, only because I just went to the meeting this morning at Dove Springs, but they mentioned particularly as part of the survey work that families who had indicated that they had mental health needs or concerns, they were going to make an effort to call them to be sure and do follow-up with them that those needs had been met. And they also had talked about perhaps collaborating more with the School of Social Work, UT, to see if there could be some relationship developed to do more follow-up that way.
Thank you very much. And if I can help with the latter, let me know.
Okay.
I'm Vice Chair
Great.
of their advisory
Great.
council.
Great.
I understand that Councilmember Mike Martinez and State Representative Eddie Rodriguez are putting together a group of people in this community to help with some fundraising. I don't know the specifics about all of this yet. I just got a call on it this morning. Do we know anything about that yet, and what their efforts will be, what they're going to try to accomplish with this committee?
I don't have any specifics of that, but I will personally contact their office.
Okay, well, as soon as I hear something too, I'll kind of let you know. But
Okay.
I do understand that they're trying to bring in some people from this community to do some fundraising, but I don't know where the money will go and if they assess the need from that community. So just thought I'd check
Thank
to see
you.
what we may know.
Thank
Okay,
you.
Thank you. Thank you. Oh, if I can just add, if y'all recall last time, was it last week, that I told you that I'd be going out and buying some items? Well, I did. I got some money from some board members here, as well as the $1,000 that the Fiesta de Independencia contributed. And I went to Walmart, and literally I did not know that it was going to be such a chore, you know. I mean, but let me tell you, I spent 3 hours at Walmart buying supplies, but it was well worth it because it was items that were needed for this community. I went and delivered them, and they was very well accepted because they were in need of these items that we took that day. So, and we just wanted y'all to know that. Okay, next item, number 2 has been postponed. So,
Madam Chair, may I make a comment on that? And I'll look to our Chair of the Budget and Finance Committee, Ms. Daniel. We did receive that report from Community Care at the Budget and Finance Committee meeting yesterday, and I have to say it's a phenomenally wonderful overview of what happened this past fiscal year. It's a good news story. So I just wanted to make sure that you have that headline in anticipation of when we do have the actual presentation.
thank you. On to number 3, receive and discuss an update on behavioral health and psychiatric services for Travis County residents.
Good
Hello.
evening.
Ellen and Dawn, good to see you guys.
Ellen Richards, Director of Planning for Central Health, and I'm here with Don Hanley, Chief Program Operations Officer for Austin Travis County Integral Care. Dawn is here with me tonight because we work closely together in this area, and she has important content expertise that I wanted her to bring to this discussion this evening. In recent months, our board has inquired about the status of behavioral health services, and so that's why we're here tonight, to give you an update and help you have the information that you need in this area. The purpose of this presentation is to give you an overview of the status of behavioral health planning. And because it's been a while since we've discussed this issue, Dawn and I are going to provide a brief overview of the last 1.5 years, as it provides a foundation for understanding the incredible changes that will happen in the next year and more beyond that. As you may all recall, there's Senator Watson and his 10 in 10. And in the spring of 2012, Senator Watson asked us to come together as a community to analyze the needs in the area of behavioral health, which is item 7 on his 10 goals in 10 years. Under the auspices of the Mayor's Office, Central Health, and ATCIC convened a process to respond to the Senator's request. We convened stakeholders across this community to garner input, identify gaps, and to establish priorities. Through this effort, we developed 2 foundational pieces to guide us as we move forward in planning for behavioral health within the 10 in 10 and beyond. The first is a list of guiding principles that we could all agree to as a community that are essential to the development of an effective behavioral health system. An effective behavioral health system has a well-developed community-based services, has a well-developed array of community-based services that help divert individuals from unnecessary utilization of crisis services and to remain stable in the community. The system also responds to consumers where they are at a given time with appropriate and sufficient services. It minimizes the use of hospital emergency departments, as these are not well equipped to address the needs of patients in crisis. And an effective system identifies ways to weave together all of the funding available to create the system. And last, but certainly not least, the system ensures that providers and organizations are accountable for the outcomes of their patients. Today, system fragmentation results in patients falling through the cracks, and it also results in overuse of expensive services. The second foundational item we developed was the mental health framework that you see on the slide here. At the top are the most expensive crisis services, and at the bottom are recovery and prevention services. The idea is that we would like a fully developed system that can meet the individual wherever he or she is and provide the appropriate level of care in a system that is based on best practices, offers culturally and linguistically appropriate services, and is accountable for patient outcomes. As a community, we have focused on the very top of the pyramid, expanding access to inpatient crisis services. While this has been important to address the needs of individuals, it has resulted in a lack of focus on services that help prevent the need for inpatient care in the first place. Those services further down in the pyramid that help individuals live stable, productive lives by either preventing the need for inpatient care or helping someone maintain health upon exiting inpatient or intensive services. Going forward, to develop an effective system, we need to focus on developing other pieces of this continuum. So going back to the 10 in 10 and its results, after many weeks of work as a community, we identified some key priorities, and this is a very high-level summary we've provided here today. In the area of crisis services, we need a continuum that addresses the needs of individuals experiencing a mental health crisis from the point of intake and evaluation through stabilization and treatment 24/7. A fuller continuum would result in fewer patients needing access to inpatient care, as most individuals resolve their crises within 48 hours. We lack specific types of services such as crisis stabilization and access to inpatient beds for individuals needing both medical and psychiatric care. In the area of outpatient services, we need to increase capacity to provide screenings, assessments, treatment, and consultations in a variety of settings. And we recommend an expansion of integrated care as a best practice to increase access. This community lacks substance abuse services, which is primarily due to lack of funding, and this is a significant gap. And tools such as telemedicine are important in the area of outpatient services and its expansion. A final key piece we identified was permanent supported housing. Providing care and then putting someone back on the streets creates a continuing cycle we all know too well. Overall, this effort identified how our system is not in any way sufficient to support the growing population in Travis County. There's an overwhelming amount of need, and the system is struggling to keep up. Now for the good news. As a result of the 10 and 10 efforts, the 1115 waiver opportunity, and other forces, a once-in-a-lifetime expansion of behavioral health services is underway in this community. And I'd like to pause for just a moment to let this sink in. We are about to see an expansion in behavioral health services that we've never seen in any of our lifetimes. 1/2 of the 4-year DSRIP projects in Travis County are for behavioral health services, and additional services are proposed through the 3-year projects. And in addition to DSRIP, there are other service expansions happening in the region that impacts the overall picture. The next few slides list the 4-year and 3-year DSRIP projects, as well as non-DSRIP projects. In the left column, you will see a letter and a number, and these correspond back to the mental health pyramid I showed you a moment ago. And this is the service category. The asterisk indicates those services that were prioritized through the 10 and 10, and the far right shows the service provider. So as you can see, just as an example here, there were a number of services we prioritized through 10 and 10 that are now coming to fruition through the 1115 waiver. Dawn is going to highlight a few examples of services, as we will not review these in depth. But before I pass it off, I'd like to let everyone know that ATCIC is hosting a grand opening of its new integrated care facility in Dove Springs on Friday evening of this week, the second item on this slide. This is a concrete example of DSRIP coming to life in this community. So I'll pass it over to Dawn.
Good evening. Thank you for having me. So I'm going to talk a little bit just about a few of the items that are on this list. This is a list of all the behavioral health services that, as Ellen said earlier, are coming to fruition through these DSRIP opportunities. But since she did tee up the Dove Springs, I know it's not bolded, but I'm going to say something about it. So we're very excited about this clinic. I hope you do come out. It's from 5 to 7 on Friday. It's an integrated healthcare clinic. We're going to have prevention services, substance use, behavioral health services, primary care services, and a large community room. And I think you're going to be impressed with the facility. It's state-of-the-art. It's something that this community is needed for some time, and we're very proud to be able to bring them this service through this unique opportunity. Back on track. Telemedicine is the first highlighted project I'm going to talk about. This is telemedicine project from the CCC, and it's for the federally qualified healthcare clinics. And what this project will be doing, just briefly, I'm not going to go through all the milestones and metrics of everything and how many everybody is serving, but it's essentially providing some psychiatric telemedicine consultation to the primary care physicians at some of these clinics right now that do not have access to any of those psychiatric care services like we do in eMERGE and some of the other community care clinics. So this is sorely needed. So it'll be consultation for the PCP. It'll also provide direct care to the clients where we can put them in front of the camera and they can have that direct consultation with the psychiatrist on the other end. The next project is the Psychiatric Emergency Department at UMCB, and this is a Seton project. It will be coming online April the 2nd. We're excited to have this opportunity in bringing this service online. It'll be licensed like a regular emergency department. It will be able to take involuntary admissions as well as voluntary if that is what the need is. It'll have 10 beds in the back, which will be primarily focusing on those involuntary admissions, and then it'll have 7 assessment rooms up front that'll work more as a triage on individuals who either walk in or someone needs a prescription refilled, and it'll actually, the parallel I like to draw it to is that it almost is going to function in a way PES currently functions. So as I go through these slides and we look at some of the system delivery, there may be some design changes in some of our existing services so that we better align these new projects as they're coming on board to make sure we're maximizing the care for the clients. It'll serve 18 years and up. They're anticipating 4 to 6 hours worth of a stay, so they're thinking there's going to be a high turnover in this facility, and they will not be taking any direct EMS transports, but they will be doing some medical screening on everybody that comes through this Psych ED service. They'll also be utilizing telemedicine. So telemedicine, earlier I just talked about one project, but there are other projects that might not be their core service, but they'll be utilizing this service as well to deliver their care. The other one is the Mobile Crisis Outreach Team expansion. Super excited about this. Oh, my voice changed, that's mine. Austin Travis County Integral Care will be providing this service. So we're taking the MCOT team and we're looking at placing a team for a jail diversion, a part of the project at Central Booking. We were looking at taking a team and placing them at the emergency departments, the highest used emergency departments, to work on that avoiding hospitalization, and then we were looking at taking a team to correspond with CIT to further prevent the jail diversions or the incarceration, and to try to divert hospitalization.
Dawn, how does that work?
How does that work?
How do you, is this somebody who's been arrested and they'd otherwise be processed through the jail, and instead they're going to be processed through this team?
Well, the goal is to catch them before the charges are ever. So we're trying to be working with the jail system and working with APD and working with the sheriff's department, trying to come up with a way to catch them before they ever get to booking. So before they're ever booked. So there's officers out in the field right now, and say they arrest someone for public urinating on the sidewalk, for instance. So instead of taking them to jail, this could, in individuals where they're suffering from some psych symptoms, this could be just, they're not clear enough to understand the difference about where they could go. And so up to this point, the only options have been really taking them to jail. Is that the best place for them? And are they getting the best treatment in that facility? No. We want to provide that psychiatric care in an outpatient setting if possible, or if we had to, in the hospital. So it's a care first focus versus an arrest first focus.
But a police officer has now got this person in custody. They picked them up, and they brought them, I guess, to the jail where this MCOT team is located. It's just that instead of processing them through the criminal justice system, they'll process them with the MCOT.
That's right, and that's the in theory. We're in the planning phase of this, so that is a piece that we're still working on, further developing on how that's going to operationalize, and because you're blending two really different systems here, and so there's a lot of conversation to be had on that. It hasn't been done before. We will be the first community to have provided this service, and it's very innovative, so it won't be easy, and that we're okay with that. It's going to be worth the challenge. So. But that's the concept. And so we're co-responding with CIT officers as well, and some of those would be where they'll make a call if they... Oh, I'm sorry. What is CIT? Crisis Intervention Team. Sorry. Acronyms.
It's okay.
It's alphabet soup. So we'll be co-responding with them, so when they're out in the field at the time, we can do the direct handoff, and we'll take them, right in, either to the Psych ED or to our existing services, and hopefully not out inpatient, because the whole focus around the waiver projects is really looking at minimizing the hospitalizations to begin with, and then minimizing the readmissions. So we want to kind of move away from that focus in the least intense or the least restrictive care. And but I'll talk a little bit more in depth with the ED diversion project, because we've actually already started that and have started to work out the kinks. So we shifted a little bit from, instead of putting the team directly in the emergency departments, we decided to go, okay, how can we catch them upstream before they ever hit EMS? So we've been working with Andy Hoffmeister and his crew, and we've run a pilot. And so I'm just going to give you some quick stats on what that pilot has already looked like so far. Within 3 months, we've done 50 calls together. 47 of those calls have resulted in a diversion from the EDs or the hospital. In 3 months. That's phenomenal. So we're really excited about what that's going to look like once we ramp it all the way up and we're fully staffed and we're moving forward in that area. So that's exciting new stuff. This next slide are the proposed projects. So the other ones we've already sent up and our CMS, I think there's a couple they're still looking at valuation before they give the final blessing on.
John, why are you talking about these that are bolded? Is there a reason why these are
Because we would
standing
be
out?
here all night if I just went down the whole list.
These
That-
are just your
Just
favorites?
the highlights. No, they're not actually my favorites. Ellen picked them.
It was just to give you a sample, an idea of some of the interventions that are happening.
So some of it's the telemedicine, which is new to our community, you know, in general, and then the clinics based, and then some of the mobile in the field type of service. So just kind of a smattering of a representation. So these are the proposed 3-year projects. I'm missing my page. There we go. I'm good. So the top 1, 2, 3, 4, we feel like we'll probably get funded, that there's going to be enough revenue left on the table where these fall, that we're feeling fairly confident that these will be projects we'll be able to add to the list. And anything below that may or may not make the list. And so these are not approved yet by CMS by any means, and it's just in its, you know, inception. So we're just getting that information together, and we have to have that all to the anchor in the full proposal by, I believe, December 13th, which is a Friday. Interesting. Just say it.
Not that we're suspicious.
Not at all. This is a representation of the service expansion of work that we've been doing in the community that's outside of the DSRIP projects. So it's important to kind of talk about what will be new through the waiver opportunities, but also what might be new and what things that we're adding outside of the waiver. So most of these, as you'll notice, fall at the top tier of the triangle. So these are crisis-oriented type of services where we've had most of the focus over the last few years around some of the planning in this area. So the DSRIP has brought an opportunity to look at the ongoing services or the continuum of care in that area. So these are adding the hospital bed opportunities, and then the recent housing bond that passed, and then proposed crisis stabilization units and what those will look like as we bring them into the system of care.
I'm sorry, there's 2 proposed 16-bed stabilization?
Mhm. I'm going to talk a little bit further on it.
Okay.
I'm going to give you a visual of kind of what these look like when they come together in the system, and hopefully that'll help answer some questions.
But yes, there are 2 proposed units. So in the next series of slides, Dawn's going to discuss how the various projects will impact the existing behavioral health system. So it'll kind of help you see where we're filling in the gaps that have existed in the system that we identified through the 10 and 10.
So these slides are provided to give that visual representation of the impact of services. So this is a look at what the current system looks like outside of any of these projects that are brought online. So the colored portion is actually tying it to the framework, the mental health framework from the triangle, only it's not in triangle form because we couldn't get it all on this page. So then you can see, we'll lay over where the projects land, and you can tell in each part of the triangle where those services are going to have an impact and where they line up. So as I talked about earlier, most of the work has been done around the crisis at that top tier or the red area, and now we're going to be able to look towards the challenges of bringing on some of these new services. So, we're missing circles.
Oh dear. They're coming.
There they go.
I didn't know this was set up like this, sorry. Okay.
Oh, that was kind of cool. Okay, so here are the projects. So that's a lot of stuff going on in that slide, and I think that is a fairly good representation about how much work is going on and how many services are going to be impacting the delivery system and where they fit on that triangle. So part of the slide is to show just the amount of influx and impact that the waiver projects will have, and it'll also show over here on the right where you can tell where that continuum of care is being built out from the mid part of the triangle, which will be that yellow and blue, down towards that darker green, the less expensive level of care, the ongoing care where we're hoping to help individuals maintain stability in that less intense level of care. So right person, right place, right time is what we're going for here, and I think this shows a good representation of that. So if you look over here before we change that slide, where EMS, POEC, the walk-in, and where it says crisis hotline is, and then you see the darker purple areas which are going to indicate where the projects are. Well, on that side where EMS, POEC, and walk-in and the mobile crisis is, that's where people were entering the system currently. And so as we go through some of these slides, you're going to see that build out. So we'll have as many people where they're impacting, where they come into the system, and then the next level is even going to flesh out further. So where do you refer from there, and then how do we get them in these other parts of the triangle into that system of care? This is the representation of those proposed projects and where that they would fit in this continuum of care in the supported housing, which is expanding a current DSRIP project, and outpatient treatment, which is going to look at filling some gaps around the integrated care delivery system. And then we have the telemedicine that we'll be able to use in the emergency departments.
What does UM mean? It's the
Utilization management.
the typical thing. Okay.
So this slide is a representation of the non-DSRIP projects and where they fit in the system. And here's what I was talking about earlier. You see the two new 16-bed CSU proposed projects. That's a pretty significant impact into the delivery system and how people will begin to be funneled through opportunities for care. And so we have the PsychED that's already on board. We have discussions around two new CSUs. So just to give you a brief explanation, a CSU is a crisis stabilization unit or an extended observation unit, which Ellen mentioned earlier. Most crises are resolved within 48 hours. So these two facilities would be able to function much like the PsychED. So it's adding capacity to take an involuntary admission to help avoid that inpatient longer stay if we're able to resolve that care at a least restrictive environment in a least expensive environment and prevent the hospital admission. These three units right here are going to be key to almost every behavioral health DSRIP project. Why? Because one of the main goals in the way that the template was set up is really focusing on those hospital readmissions or hospital admissions, keeping that rate down. So if you're utilizing these services versus your inpatient, then you're having a significant impact on what those outcome measures will be for all those other projects. So those are very, very key.
When you say three, there's the two 16-bed crisis stabilization.
Well, I'm counting the PsychED.
Okay.
Yeah. It's smaller, but not as much. So they're looking to stay for a less amount of time at the PsychED than you'd be able to stay at the 16-bed CSUs. And in here, you can take voluntary or involuntary. So we would have that flexibility to move people who are kind of right on the cusp before, where APD or the Sheriff's Department would have an individual and they're like, I don't know what to do with them. I don't want to take them here, so they take them to the hospital. So this would give them another opportunity to get them into the right appropriate level of care.
So it not only diverts people from inpatient, but it also is a place for law enforcement to take patients instead of taking them to the emergency departments. So with the combination of three facilities, the PsychED and these two CSUs, we think we will have enough capacity in the community to really draw off of the emergency departments across the community. So it's a significant resource to address the issues that the hospitals have been facing.
And Ellen, where will they be built, or
Well, that's part of the planning. It's still in the proposed kind of conceptual model.
So these aren't DSRIP, these are just
These are not
wish lists.
DSRIP, these are
Wish
separate.
lists.
And we, David Evans and I came forward to speak about what that crisis delivery system might look like and gave an idea of how the PsychED may fit into that picture. So I think this is just further work. It goes back to the guiding principles. One of the guiding principles comments was on better connectivity between services. That's going to be key because we have so many good services coming on board, and if we're going to have a significant impact and be providing that quality care, we're really going to have to refine how we triage individuals in our system and getting them referred to the appropriate level of care.
So these two are not cited and they're not funded, but they are definitely identified by ATCIC and I assume by us,
Right.
you two, as what we need. And
Right.
and so
So we want to
now we
bring
just
those
gotta
on
do it.
board.
Yeah, okay.
Yes.
May I ask a question? Need, are they meeting the capacity need, or are they, the additional beds meeting a screening processing need? Well, I know they're meeting both. I guess my point is,
That would
are the additional beds enough to provide adequate capacity to meet the projected use over a short period of time? Or are we building something that's too small? It addresses a need, but it will be insufficient in 5 years, let's say.
So we've done some rough calculations, and we feel that the combination of the 3 facilities, again, the Psyche D and the 2 CSUs, will be sufficient to meet the need. That, and we're looking at both, we're looking at things like how many people are law enforcement bringing to the EDs now to make those calculations. So I can't say definitively, and I'm not sure if Dawn can either, but we have done some calculations to try to estimate that.
And so the goal would be to, in utilizing these new services, of course, we want to have less use of the inpatient facilities. And as the district project, as you saw in the earlier slides, we've really built out that continuum of care. So bringing all these on together, we're hoping to make a significant impact in that gap.
Because our population continues to grow
Right.
at a rapid pace. But
Yeah.
while I have your attention, may I ask one question for clarification? I don't have the page here, but service expansion projects, S2 and S2, S2 and S4. No, S2 and S2. What is the difference between school-based behavioral health and campus-based counseling?
Very good question.
And I noticed that AISD, of course, is the largest system, but it does not have a school-based behavioral health program. It's rather campus-based.
So the difference between the 2 projects, so one, the campus-based is more on a referral type situation where you have a team on campus and they're utilizing the school nurse to make the referrals for care around the behavioral health need. The difference between the other project is it's an integrated campus. It's actually a campus-based project as well, but it's not just providing counseling. It's providing primary care and counseling or behavioral health care on campus at these outlying schools that don't have these other services. Because as we all know, the population is growing out. So these outlying schools are really stretched as far as what their resources are. And this was an opportunity for us to reach out to those other school districts and expand that. So we're also hoping to be able to circle back around to AISD and incorporate this integrated care model into some of their existing mental health delivery system on campus as well.
Thank you.
The districts all approach services differently in terms of healthcare services. AISD doesn't have clinics on its campus, but some of these outlying districts are starting to look at school-based clinics, and so it varies.
And it varies by campus. Campus by campus has a different, depending on who's the lead in that area.
Right.
Thank you.
We have another question for you over here.
Sure, I just wanted to add something to Kirk's question, which is you were asking about would the number of beds be sufficient, did we need more? And Dawn adequately answered that, of course. What I want to remind you is that if there's a need for more beds, it's not more beds being added to a 16-bed unit. It would be yet another 16-bed unit.
Yeah.
So it's away from the institutional approach, which is something greater than X, if you will. So it would be another 16-bed crisis stabilization unit, not more beds added to an existing unit.
That is just, the question I had, Brenda, is why 2 16-bed units rather than a 32-bed unit? And it's because you want to multi-place it, or, I mean, there
Well,
must be.
I think that's a two-pronged answer. One, yes, logistically, you could put them at both ends, right, for geographic location. But 2, for sustainability. In order to be able to bill for these services, there's, and I'm going to forget what this acronym stands for, but Brenda can help me. The IMD rule, you can't bill for services, for behavioral health services if you have more than 16 beds.
Institute for Mental Disorders.
That's it. So we would have to keep it at the 16-bed facility so we could sustain the services.
Very
it's
complicated
So it's a billing funding and it's a logistics
Okay.
opportunity.
I knew you had a reason.
Okay. So I know this is a lot of information, so here's the Cliff Notes on impact. What we hope will be the impact of all of these additional services, that more people will receive treatment in the right setting for less cost, will reduce inappropriate use of inpatient or other intensive services. We anticipate a possible increase in need for ongoing outpatient counseling services. So as we move people back into the community to receive the appropriate level of care, we may need more support services in the community to keep people stable. And we need to address the operational issues and transitions and connections between services as new services come online, as Dawn said. So there's going to be an impact to the existing system, where we're going to really need to watch how these new services come into play, and how they're connecting to existing services, and work out the kinks among them. And I know that an example of an issue that's on everyone's mind, do we need more inpatient beds? This is a question that we talk about a lot. And we don't know the answer to this at this point, but we expect that the addition of these services that we've shown you here will significantly impact the need for inpatient services, and that it will reduce the need for those services, because people who are using those services now inappropriately will be getting care in a more appropriate setting at a lower level.
May I add an observation, please? In the area of mental health, housing, the lack thereof, is a major contributor to lack of continuity of care, instability. Homelessness is a huge problem. So to what extent are you partnering with or addressing the housing needs of this patient population?
So in the 10 and 10 work that we did in April of 2012, one of the priorities we identified was permanent supported housing, specifically for this reason, that we understood that you can provide treatment to somebody, but if you put them back out on the street, it's kind of pointless. So we identified that as a priority, and we do have projects in the waiver that are what I'll call wrap supports for permanent supported housing. We weren't allowed to do housing specifically in the waiver, but we have wrap supports that can support existing housing or housing that's coming online through the city or other organizations. And additionally, we noted in there that there was a recent bond election that has passed that will provide more permanent supported housing in this community, and we recognize that it's a really important piece of all of this.
That's what is meant by the wrap supports.
Right. Yeah, and sorry, I know we have a lot of acronyms in here because there's just not enough space to write everything out, but ACT for PISH and WRAP for PISH has to do with permanent supported housing.
Thank you.
Okay. So while a lot has been accomplished, we are not standing still. And today we're at a bit of a painful spot, lots of need. We know that more services are coming, but aren't here yet, and we're anxious to have a system that functions well and meets the need. Going forward, we need to understand the impact of all of these new services coming online. How does this impact the gaps that we've identified, and where will we need to focus next? We know we still have a significant gap in substance use services, and efforts are underway to focus planning in this area, and it's being led by ATCIC. We're grateful to them for taking on this leadership role. We need to reevaluate the best use of the psych stakeholders and crisis intervention committees, and shift the focus of the organizations around the table so that they are working in alignment with where the world is today, different from where it was when we started those groups in 2005. And per the direction of this board, we will be building on the work completed to date to lay out the next priorities in behavioral health. And I'm pleased to let you know that our new senior healthcare planner, Lisa Owens, focused on behavioral health, started on Monday and is already digging into the work that needs to be done. And she's excited to help move us forward in this area. And so I'd ask Lisa to just stand up and say hello. We're really grateful to have her on board, and I think she's going to be a terrific help to us. So with that, we're happy to answer any further questions you have or receive any comments.
Anyone? Yes, Clark?
Just, I would appreciate your talking a little bit about how you're approaching the substance abuse issue. which, I mean, all I've heard is kind of the bullet points on this, which is it's obviously a huge component of having a lasting impact on the folks that we're trying to address here. And yet, we don't have any money in the system to pay for it, and it's very expensive. Have other communities dealt with this in a better way than we have so far? What are ideas about how we're going to take that on? But we obviously have to take it on, and yet I don't know where the money comes from.
No, you're absolutely right. You know, and when we're looking at the number of individuals that are frequent or high utilizers of our crisis system, many of those have that co-occurring mental health and substance use diagnosis. And so we haven't been able to put our finger on that, excuse me, on how to solve that, because the resources have just not been there, just exactly like you brought up. So what we want to do are bring the key partners together to look at how we can leverage some of our community resources maybe in a different way, reaching out to what are some of these other communities doing, providing consultants opportunities to help us weed through some of this. So we know it's a need, we know it's impacting our system, but the way the reimbursements are set up through insurance companies, through Medicaid, it doesn't make the service whole. So you can't pay for the cost of the service, and it is very expensive. But what's unique about substance use services is it's not like you come in with an infection and you get an antibiotic and then you're going to be good to go in a few days. You're going to come back through treatment, and you're going to need to come through multiple times. And when we build this system out, we have to be able to have components that are ready to meet people where they are in their treatment journey. Because people aren't at the same level as far as, you know, how you sober up and then what that means. They're at different levels of care, and we have to be able to have those different levels of care available for them to truly build out that full continuum around those services. And we need to integrate that into our primary care work, into our behavioral health, our mental health work, with that substance use. So that's blending all three of those together. We're doing a good job around the primary care and mental health and expanding that and getting physicians comfortable and therapists comfortable in each other's scope of work. So this is the other piece that we're lacking, that we need to bring on board. So it's going to be a big job, and we don't have the answers to start with, but we're going to bring the people together to walk through that journey and to hopefully start working on leveraging some of those resources.
To me, that's just a huge component of this massive bet or project that we have embarked on in our partnerships, and so we got to come up with the answer to that. We're going to be able to document that we're doing what you said in the first bullet on your last slide, which is we're doing more, having better impact on these folks for less money.
Yeah, you're absolutely right.
Clark, if I may, regarding substance abuse, other than your memorandum, which is attached to the material dated November 14th, there's a call to action to this board. Do you want to address that? Shall I refresh your recollection?
No, I know what it is. So, yeah, okay, so let me just finish.
You're under Crawford. Raise your right hand.
Yeah.
Sorry.
Are there any more questions or comments about
Yes.
this presentation before I move to that? And I will speak to those remarks.
I have two. One is a question I get asked all the time related to recent incidents in our community where the Austin Police Department has shown up at a residential location where they've tried to de-escalate a situation, and regrettably the outcomes are not what we want. And people ask me, why wasn't MCOT, the Mobile Crisis Outreach Team, there? There's a very good reason in terms of protocol that relates to safety. And I think in terms of managing expectations, if you could just talk a minute about that in terms of the Mobile Crisis Outreach Team role relative to such situations and APD.
Mm-hmm. Sure. So Mobile Crisis Outreach does have levels of response. So there's urgent, emergent, and routine calls, and that's based on, you know, how quickly that we're needed at the scene. But right at the standard of care around this treatment team delivery is safety. And so those are part of the parameters that we triage when we're taking a call. And oftentimes APD will tell us don't respond.
Yeah.
Because they don't want to put us in harm's way. So even if it's a client that we may know or it's not, or we know it's a mental health call, if that's their first thing, even when we co-respond, is they go in and they secure the scene first. So I'm learning all my law enforcement lingo. But that's the first point. Look at the house, look at the family, make sure the environment is safe, then bring in the MCOT team. So we don't go into situations that may put the therapist at risk.
Yeah, I just think it's very important for the public to know that, because they wonder, well, why not? And there's a very good and valid reason for that.
Right.
Secondly, a major event happened in the mental health arena in terms of reaffirming the parity for mental health and substance use within insurance policies. You want to talk briefly about that? Because it's bifurcated in a way, but.
I'm not sure I have enough information to talk about that.
So what happened is the reaffirmation by the current administration that in private health insurance plans, that you will not be limited to your 20/20, meaning 20
Okay.
mental health visits and 20 substance use visits, if you will, for care, that you'll have the equal amount of services available as you do for your physical health.
That's right.
And so that's a major issue. And one of the, I guess, criticisms is that, well, what about the people who are on Medicaid, Medicare, and other publicly funded systems? When is that parity going to come about, which is yet to come to full circle fruition? But that was a major issue in terms of that parity being reinforced.
You're right. I think that, to bring to our attention too, as we look at mental health services, I mean, this is a public health concern. I think we've taken more of a focus around it being a public safety concern, when really public safety is the symptom of the larger problem not being addressed in the health arena. So mental health services, in our opinion, need to be just as important as the public health strategies around how we've worked with our youth on, tobacco cessation or not binge drinking, and we've got all these public announcements about, click it or ticket, put your seatbelt on so you can stay safe. That same attention and that same campaign needs to be moved towards the mental health arena, so that we're opening the doors to service, people have access, we're reducing the stigma, so it becomes a part of your regular care of going to see your primary care physician. This is just part of your whole health, so we connect the head to the body, we don't separate it, and we provide the whole service to the whole person.
Thank you.
Thanks a lot.
So I'm piggybacking on this item to talk briefly about the psych stakeholders notes that are in your packet. We had a little glitch, and those are supposed to come under another item, and it didn't end up there. So psych stakeholders did meet in October, and I'll just highlight a couple of things. One was we had a presentation by Mr. Leonard Kincaid, who runs the Houston Recovery Center, which is Houston's answer to Sobering Up. And these are people who are picked up for public intoxication, and it's a diversion program to divert them from being booked into the jails. And so Houston's been up and running for a few months, and they've had some very good results. They're not at capacity yet, but quickly getting there. And so they're studying their data and figuring out, tweaking their system to make sure that it works the way it needs to. And one of the things that they originally didn't staff for mental health issues, but have discovered that they do need to have psych techs on staff to address issues that come up. And they offer the opportunity for anybody that comes into the facility to be connected to other services to address their problem, should they so choose. It is a voluntary program, but they feel like they're working effectively to keep people there until they're safe to go home. So that was a very interesting discussion, and it has triggered a lot of discussion in the community about whether Austin may pursue something like this. And so there are some discussions that are happening at the city around a possible facility like this, but it's in nascent stage discussion. At that meeting also, there was discussion about substance use planning for this community and how we need to approach that. ATCIC, David Evans has stepped up to the plate and said that ATCIC is willing to serve in the role of doing substance use planning, but is interested in having their three appointing bodies, City of Austin, Travis County, and Central Health, give them the go-ahead to serve in that capacity. And so we are working at the staff level to provide that official approval or whatever is needed for them to feel comfortable taking on that role. But there are meetings actually already happening in that area, and Dawn can speak to them if you're interested in knowing about that.
Can I ask a quick question, Mr. Separate? Does the sought after approval to go ahead translate into funding?
I don't believe so.
Okay.
No, there hasn't been any discussion of that, and I don't think there's any expectation of that.
Okay.
But somebody's gonna have to show up with some dough at some point on
Yeah.
that issue.
Right.
And it sounds to me like it's gonna need to be everybody. We're gonna have to spread it out.
That's why there's an open invitation.
Yeah.
To
Good
the three
question.
governmental entities.
The sobering up unit specifically, I think, is a huge benefit to, on the public safety side. And so it's an opportunity to really cut costs in that area. And so I wouldn't necessarily think that that would be something we would be interfacing on, but maybe on a more treatment-focused area. So, any other questions?
Great presentation.
Thank y'all.
Good job, thank you.
That's important work. Thank you.
Thank you.
Yeah.
Okay, on to number 4. Discuss and take appropriate action on an agreement with Cope Health Solutions for Delivery System Reform Incentive Payment Project Consulting Services for the Community Care Collaborative. Jeff?
While they're setting up, Rosie, may I ask you a question? I'm just a little confused about some of the paperwork we have in front of us. We got handed a really fat board packet, and then we got handed a smaller one. Is there one we're supposed to go to versus the other? The fat one. Okay, and then the little one was just an extra. Okay, thanks. Thank you. I keep going back and forth. Thank you.
Go ahead.
Okay, thank you. Jeff Knoble, Chief Financial Officer of Central Health, and with me is Mark Hernandez, Dr. Mark Hernandez, the Chief Medical Officer of the Community Care Collaborative. What we have before you today is a proposed contract with Cope Health Solutions, and this is a proposed contract between the Community Care Collaborative and Cope Health Solutions. And just getting back to the master agreement, one of the reserve powers of the Central Health Board is that any contract that is above $100,000 that the Community Care Collaborative is seeking approval on requires approval of the Central Health Board. So again, this is a contract between the Community Care Collaborative and Cope Health Solutions that requires the approval of the Central Health Board. Real quickly, we have been through a few different approval processes. We've taken the proposed contract to the Community Care Advisory Committee, who recommended approval of the contract to the Community Care Collaborative Board of Directors. We've also presented to the Central Health Budget and Finance Committee, and they've recommended approval of this contract to the Central Health Board. And then yesterday, we also presented in front of the Community Care Collaborative Board of Directors, and they approved the contract contingent on approval from the Central Health Board of Managers. Just a quick fact sheet on who we are contracting with. And again, not again, I've done this a lot, it seems like it's again. Sorry. We currently have engaged with Cope Health Solutions related to project management services for demonstration year 2. It was one of the initial contracts that the CCC entered into about in June of last year. Remember, we had a startup budget. This was one of the contracts, and it was real important that we begin the demonstration year 2 Deseret projects. So they were managing the projects, and I'll have a slide in here that kind of updates the board on where we're at on demonstration year 2 as it relates to that contract. And just remembering, it was a So we engaged it in June. The contract term was through October 31st, and it was about $1.5 million. So just to refresh everyone's memory on that. So just a couple of quick facts about Cope Health Solutions. They are a nonprofit corporation established in 1995 by UCLA student volunteers with a common goal to make a difference in the community. And their initial goal was to provide a health education to the under and uninsured in Los Angeles County. They did have some California 1115 waiver experience. One of the things that attracted us to their experience as it relates to the Texas 1115 waiver is they had done a lot of work in Region 10, which is Tarrant County, specifically working with JPS, who's the anchor entity in Region 10, and had done a lot of good work there. And again, as I mentioned, we had contracted with them in demonstration year 2 for the 1115 waiver. This again is just a reminder of our Deseret project timeline. The contract term that we're presenting on this item is for demonstration year 3. You'll see that that's our year of implementation. And then down below you see the proposed valuation of our Deseret projects. Noting in demonstration year 3, we have $58.3 million of possible Deseret project valuation, and this also includes our new 3-year project that was recently proposed, our pregnancy centering project. So $58.3 million in our implementation year for these 15 projects. Just a quick recap on our demonstration year 2 progress. We have reported to HHSC our metrics and milestones on 13 of the CCC projects. 11 of those have been approved. Our 2 specialty projects are still awaiting approval. I think the going status is hopefully next week we will hear something. We don't have any reason to believe at this time they won't be approved, but we have not seen formal approval yet. And then, of course, we had a replacement project, our patient navigation project. We have not received approval on that, and it will be heading to CMS in December. As it relates to specifically what we did, of the 13 projects, we reported 100% of the milestones achieved in all the categories, and of those projects, that's a little over $49 million in total valuation, and included in that valuation would be the local plus the federal share. So in the CCC, were we to receive approval from CMS and HHSC on all of those metrics and milestones, we would receive the $49.2 million. Specifically, as it relates to the proposed contract with Cope Health Solutions for demonstration year 3, there are 2 primary areas related around the contract. Project management of the Deseret projects, and then information technology. And I think last week we had a presentation on the information technology piece, or the HIE piece of what we're doing both in the community and as it relates to Deseret. So specifically as it relates to project management of the Deseret projects, I've just outlined some of the tasks associated with that, including monitoring the project execution of the actual Deseret projects, the quality assurance of the deliverables, regulatory compliance and reviews, and also assistance, and that's really important. We get a lot of inquiries periodically from HHSC related to just the Deseret project process and they've been extremely helpful in helping us respond to those. And then the last piece of it, which is really important also, is the performance improvement oversight, including performance improvement as it relates to our DESREP projects, helping us identify any performance gaps in the projects and fixing those potential performance gaps and helping the projects become efficiently performed through some of the tools that they have employed. They have a performance improvement, I'll call expert, because I think he is an expert, on staff, and he's been, he will be on the project during this contract period, and he will help us deploy several different advanced performance improvement methodologies. The second piece of the contract, the scope of services, relates to information technology, and again, this would be related to the CCC Chief Information Officer interim duties, providing technical support and functional requirements as it relates to the health information exchange vision, both for the integrated delivery system and the DESREP projects, and then aligning the technical strategies with both clinical and operational needs and coordinating amongst all the partners as it relates to developing the HIE. The terms of the contract, the contract period again for demonstration year 3, so the contract term would be November through the end of October of 2014. The proposed contract value is a little over $4.5 million, and you see below that kind of the breakdown of the $4.5 million. You see a base amount of $3.7 million. One of the things that we wanted to incorporate into this contract was a performance incentive-based contract, and so there are performance incentives of about $437,000 in this contract, and I'll go over that in a slide here shortly, and then a contingency amount of $419,000. Just a breakdown as it relates to the cost of services and the contract amount. The DESREP project management amount is a little over $2.4 million. The information technology is $1.2 million for a contract-based total of $3.7 million. And again, you see the incentives and the contingency amounts for a total contract amount of $4.5 million. A little detail on the performance incentives. The way that we looked at the performance incentives was to identify actual DESREP revenue that the Community Care Collaborative receives. As a reminder, for our approved fiscal year 2014 budget, we approved 90% of our demonstration year 2 revenue as kind of a benchmark to budget towards, and again, budgeting is just an estimate, so it was an estimate, and we feel like it was a conservative estimate, certainly based on what we know now. But again, just during the budgeting process, we felt like 90% was an appropriate mark. And so we built these incentives based on achieving above and beyond what our budgeted amount would be. And so you see that if the Community Care Collaborative actually receives 95% of its potential total DESREP revenue, we would pay a performance incentive of a little over $182,000, and then $73,000 if we receive 98% or above, for a total incentive in demonstration year 2 of $255,000. And then it's the same process in demonstration year 3, although it's a little lesser amount. So you'll see $109,000 achieving 95%, again 72,000, receiving 98%. The total for both demonstration year 2 and demonstration year 3 would be $437,000 for a performance incentive.
So Jeff, how much is each additional percentage? How much additional revenue is each? Is it somewhere here and I missed it?
Yeah, no, that's a
Is
good
it-
question,
oh.
and I'm just going to flip. That's a great lead into the next slide. We have a total potential valuation in demonstration year of $54.6 million, and you'll see this is the $49.1 million. The top row is the 90%. So for each additional percentage that we would receive above 90%, it would be a little over $500,000. So, for example, were we to achieve 95% of Deseret revenue, the Community Care Collaborative would receive approximately $2.5 million above and beyond what we budgeted. And then we would, of course, pay the performance incentive of $182,000. And then it just goes 98% would be an additional $1.5 million. And again, we would pay the $72,000. So we feel like it's a good incentive, certainly for our contractor. You know, we've reported our metrics and milestones to HHSC and CMS. We reported at the end of October. We should hear back by the end of, or in the middle of January, and we'll have a short period of time for any corrective action. And then if there's any remaining that's not approved, we'll have another chance at submitting that for approval. So we think that it's real important to keep an incentive out there for incenting additional Deseret revenue. You'll also see under the uses, and again, this is the Community Care Collaborative approved budget for fiscal year 14. You'll see under uses the second line called Deseret project cost of almost $21.6 million. That's the funding source. That would be the funding source for this contract. And let me go into just a little bit more detail as it relates to the Deseret project budget of $21.6 million. Again, as we went through the budget process 4 or 5 months ago, we had estimates as it related to building a budget as it relates to the projects. We developed 3 categories as it relates to our Deseret project budget. The first being Deseret projects provider services, and these are providers. This is a budget for providers that the CCC will contract with in the performance of those contracts. And what we would expect to see in demonstration year 3, our year of implementation, is this. We expect this to be a base amount, but we would expect this amount to increase over time into demonstration years 4 and 5 as we ramp up our projects. In other words, our metrics, or our throughput on our projects, our metrics and milestones will increase as we get into our future years, and we're required to produce outcomes as it relates to those projects. Conversely, on the health information technology budget, which you see is $8 million, being in an implementation stage on an information technology project, generally your costs are higher as you implement and develop these information technology projects. And so we feel like we've budgeted conservatively on our information technology project, but we would like to think that over time the budget for these in these future years will decrease as we build the system and we bring it into operation. So it kind of gives you a little contrast as far as budgetarily why those numbers are they're fairly similar, fairly close. but we would expect them to take different paths over time. And then you see a project management budget of $2.8 million, and that, again, was our estimate based on 4 or 5 months ago, what we assumed would be our project management costs. The way that we're looking at this contract and the way we're looking at the budget, the help, and I'm just going to flip back a couple of slides, the information technology portion of that would be in the information technology, I'll just call it budget bucket, so to speak. And then, of course, the Deseret project management cost of 2.4 plus the incentives, and we really don't know what the contingency would be. It's, you know, I would just, at this point, estimate that we would be pulling that from the project management budget, the $2.8 million. So again, these are sub kind of activities as it relates to our Deseret project budget. Our total budget for fiscal year 14 is $21.6 million, and we certainly expect to bring some additional information technology and provider service contracts, hopefully in the very near future, to begin implementing our Deseret projects. So with that, staff recommendation is that the Central Health Board consider and approve the contract with Cope Health Solutions for an amount not to exceed $4,575,000. Try it again, $4,575,078. So with that, I'll take any questions either for myself or, this is my first presentation where if there's anything you need to add, Mark, I guess I kind of realized at some point.
You know, you were on a roll. You didn't need any help from me, but
Okay.
I'm happy to answer any other questions as well. So,
Questions or comments? Yes, let's start over there and come on this way. It seems like we might have quite a few questions. So.
I support the recommendation, but I would like, if my colleagues agree, some assurance that COPE is going to help the CCC establish its own operational and FTE infrastructure to assume these project oversight and continued implementation of the system that we're building. For example, if we spend $8 million on health information technology, at the end of their contract in October 2014, that system still needs administrative and management support. And if we don't have the capacity, obviously we don't, because we're paying these folks a fair sum of money for their expertise. At some point during this process, they need to help us establish the capacity to continue the fine work that they're doing. So is that built into the contract?
So a couple of things I would say about that. So kind of boiled into the contract and the agreement with COPE was the notion of what is the overall staffing plan that's required to implement demonstration year 3. And inherent in that was not just what COPE would be supplying, but also what the CCC needed to bring, because the notion was never that we were buying all of this work from COPE to do, and that they would be bringing all the individuals to bear to do all the work. But there was already kind of an agreement that this is our part, this is your part. We need to figure out how we're going to work together as a team, but also inherent in that, and I would say, Kirk, not just in the area of HIT, though that's clearly a critical one, but also in areas such as project management, there is this notion of phasing out their project management and putting in our own. And so, you know, over time, we will slowly begin to back out the consultants and bring in our own expertise. I think it's interesting. I'll offer a comment. Nobody's asked the question yet, so I hope I don't preempt somebody's question, but if you looked at the incentives and you noticed that the DY2 incentives in value were higher than the DY3 incentives, and you might wonder, the contract's bigger, but the incentive shrunk in terms of the DY2 contract and the DY3 contract. That's because more of the work in DY3 is execution work, and that's actually on staff. and it's on our contracted service providers to do the implementation work. And so COPE is critical in helping us be able to plan and begin that implementation as well as to do the HIT piece. But the heavy lifting is ours. And so a lot of this work is not just you're here to do the work, it's how do we work together and me learn how to do what you're doing so you can go away. And we can continue to do this work once you're not here.
And also, just to close, my understanding from staff is this is a recommendation for funding not to exceed the recommended level, correct?
That's right.
Thank you.
Okay, coming this way. Katrina, do you have any questions?
No, I'm.
Okay, good. Okay, Brenda?
Just two comments. Yesterday in the Budget and Finance Committee, we talked about two specific items. One, which you just addressed now, about the tailing off, if you will, of the expenditures, because this is, if you will, a startup in infrastructure. The second question was the total amount of funds expended with COPE to date when we add these to it.
Right, so, so we have two pieces of that. We have just the Deseret piece of it. Again, as it relates to demonstration year 2, we have $1.5 million contract, and then we're proposing this contract, which would be $4.5 million. So that's $6 million. Plus, we have some consulting as it relates to Central Health, and we have this strategic alignment, and that totals up about $1.1 million as it relates to a Central Health contract for the strategic alignment of both Central Health and Sendero and Community Care helping us with those services.
Thank you.
Thank you.
This way.
I've been very impressed with the COPE people, both the technical people and the healthcare people. When you look at the importance of these projects to the bottom line of the CCC and our work, you know, you can get there on this contract. I guess, I think, Mark, you mentioned that there had been some analysis kind of on the amount of staff hours that would be involved, and I guess I'm just, are there hourly rates implied in this number?
In regards to this COPE's?
Yeah.
Yeah,
Yes.
there are actually, it specifies number of hours and hourly
You've
rates.
basically seen the breakdown on the costs. And,
Yeah, it was
and
part
looked
of-
through all that,
Mhm.
and are comfortable with those in terms of.
Those amounts were negotiated, so they weren't
Okay.
necessarily accepted as they were originally
I'm
presented,
just
but
assuming
after
we're
some
talking about a
negotiations.
tremendous amount of work here. In terms of
Yes.
just the number of person hours that are going to be involved, and they're going to be compressed in a short period of time, in which we'll either perform or we won't. If we do, we'll get all this money. If we don't, we won't.
We won't get paid.
Yeah.
Yeah, it's and again, they gave us a staffing estimate, and I used the word estimate just as a basis to negotiate the contract. I think we got comfortable with it, and then.
With the
ended up-
rates on a.
And then negotiated.
Unit basis.
That's correct.
Okay.
Correct.
Well, just for the record, I'm sorry, I'm a lawyer, since we're, I don't want there to be any ambiguity. That last piece about if we complete the work, we get paid, and if we don't, we won't. Would you like to clarify that? In terms of the risk shifting, if there's a failure to perform, and if we don't receive additional funding, what risk is COPE assuming in the contract, if any?
Well, first of all, the clarification as it relates to Deseret is the Deseret projects have specific metrics and milestones and outcomes, and the outcomes really become more reinforced in years 4 and 5. But as it relates to Deseret projects, you achieve the metrics and milestones and outcomes to get paid. If you don't perform those or you don't meet those, you have two opportunities to either possibly receive partial payment, or there's a certain period of time where you can, and I'm just going to use this word loosely, you can make up for that time. So there's a lot of risk as it relates to execution of the Deseret projects. Bottom line is either you perform and get paid, or you don't perform and you don't
Yes,
get
sir.
paid.
And that pertains to the
And that's,
CCC.
and that's the CCC and the Deseret projects. As it relates to the contract, you know, certainly from our standpoint, the CCC standpoint, it's our job to make sure that we're satisfied with the performance of COPE and that we feel like we're making, you know, the necessary progress in order to meet that desired state. So, you know, we're certainly inheriting that risk. We'll certainly impart, you know, the necessary guidance to the consultant. But there is, you know, from a performance standpoint, we'll monitor that. There is not a provision in here that shifts a tremendous amount of risk to the contractor as it relates to performance of the CCC as it relates to the projects. I think it's incumbent on us that we're satisfied with the progress we're making and that we're gonna execute the projects in a satisfactory manner, and they're doing the things that they need to do to ensure that.
I would offer that also that though we recognize that COPE is crucially important, particularly at this key juncture, to help us achieve what we need to achieve in DY3, the CCC staff is responsible for the success of the Deseret projects. Ultimate responsibility lies with us, not with the consultant. And so towards that end, the consultant is not being handed the keys to the car and told, drive us to the location, and we're going to be taking a nap in the back. And we trust that we've incented you correctly so that we get where we're going. There will be close monitoring, and frankly, we're working closely together. So I think that if I have no doubts about this particular company and the work they've done for us so far, and I think my colleagues agree with that, or we wouldn't be coming before you to ask for your approval of this contract. But having said that, responsibility is ours, not theirs. We intend to work closely with them and ensure that we are getting from them what we're paying for, in addition to the hard work we're going to have to do to ensure that we're successful ultimately.
Thank you.
Rebecca, we'll go Rebecca and then Trish. I think you had a question or comment. Go ahead, Rebecca.
I have a big question in terms of the timing of the contracts and the work on the performance incentives for DY2. DY2 is over, right?
Yes. So DY2 ended September 30th, excuse me, I stand corrected by myself. September 30th of 2014, DY2 ended in terms of work. You had to have had all your work completed by the end of that.
Right.
Reporting of that work was encompassed in the next month, so all the reporting requirement ended on October 31st. And so yes, it does appear odd that we are building an incentive into a contract for work that's already been done, except it's not technically complete. Because what happens now is, and jump in here if I say something factually incorrect, I'm sure you will anyway. As CMS is reviewing our data, essentially all of the reported measures that we have to give them, they get the opportunity to provide us feedback and say, well, you did these 40 things right, and on these 20 we have questions. And we're not going to approve your payment on those 20 until you've answered our questions appropriately. At that point, COPE remains on the hook to ensure that we answer those questions correctly of CMS. I mean, I guess the ideal state would be CMS would tell us that we hit them all, and in some ways you would say that that was unnecessary. But on the other hand, there is real work that may come back from CMS around what we've delivered. What we have reported is 100% of everything we were told to report. That doesn't mean that they've graded it yet. It means that we have submitted to them everything that they asked for with no omissions.
And right now, we have valued what we've done in DY2 at 49
That's
million.
correct.
But we have a potential of 54.
Right, because that represented 90% of the total amount that we could be paid.
No, that's
Is that-
what we've submitted as far as our projects that have been approved, the 11 projects, plus we had 2 specialty projects that were supposed to have been approved prior to submission. They haven't been, but they told us, go ahead and submit those metrics if you've achieved those. So the difference is our navigation project, our replacement project,
Okay.
which hasn't been submitted, will be submitted in December. The good news on that is we have achieved the metrics for that already. So we're hopeful for a quick approval process, and then we would submit that at a subsequent date.
Okay, and so just so I understand, so the performance incentives for DY2 is to assure that COPE continues to help us in packaging the information in a way that CMS recognizes that we've met the metrics.
It's the final process, and quite honestly, we don't know what that entails. If there are some metrics that aren't approved in this submission, then we have another opportunity, I think, in July or so, and we would expect them to fully participate in that resubmission process.
I got it, thank you.
Okay. Trish?
I just wanted to clarify something. When we're talking about performance metrics and milestones and outcomes, those are not just things that we do. We have contracted providers that are actually performing the services which are the basis of these projects. So is therefore also their performance that drives. It's not the management of their performance, it's their actual performance that drives whether we earn the money or not. So I'm just highlighting that there's not one single responsibility for this. It is a collective product that we are producing here.
I agree. Stand correct.
Okay. Any other comments or questions? Okay, so the ask from staff is you're recommending the approval of this contract. It went to Budget Finance yesterday.
We approved it. So would you like me to make a motion?
Yes, I would love that. Thank you.
I move that the board approve an agreement with COPE Health Solutions for delivery system reform incentive payment, project consulting services, in an amount not to exceed $4,575,078 for the Community Care Collaborative as presented by staff.
Okay, so if I may just ask this question of our attorney over here, this went to the CCC yesterday?
Yes.
Is that correct? And tell me, did they approve it exactly as we just made? Or was there a difference? Do we need to adjust anything?
Can I interject?
Yes.
So the CCC Board of Directors did approve the contract. The stipulation that they made was that if in the contingency amount, if an amount that it would exceed $100,000 was to be utilized in the contingency amount. And again, this is the, let me flip back to that, the $419,000, that it requires approval of the CCC Board of Directors. So it would be an item that we would have to take back to the CCC Board of Approval to use an amount greater than $100,000 of the contingency amount.
Okay, so with that, does our motion have to mirror the same as theirs?
It should, because this is a reserve power, and as reserve power seeking board representation on the CCC board, affirmed that was the action SEEK was taking, and this is the action Central Health was taking, so they should be aligned.
So would I amend my motion to add that if the an expenditure greater than $100,000 of contingency funds were to be needed, right? That it needs to also go to the CCC board for approval. Is that right?
But not Central Health.
But not back to Budget and Finance or the full Central Health Board.
There we go. Okay. Okay.
Is that clear? Okay.
Is it clear to everybody? That was, yes? Okay. So.
Second.
Okay. Any further discussion? All in favor signify by saying aye. Aye. Any opposed? And I think Dr. Coopwood abstains. Okay? Thank you for that. Thank you to the two of y'all. Okay, number 5, discuss and take appropriate action on an agreement with Bartlett General Contractors for construction manager at risk services for the Southeast Health and Wellness Center.
I'm Larry Wallace again, and Bob Kallstrom, our project manager for this project, along with Tina Southwell, our purchasing manager, are going to present this item. We made some modifications and changes based on the input we received yesterday from Budget and Finance. And the only thing I would add is the fact that we are planning another series of meetings with the community to keep them engaged. We committed that we would keep them involved every step of the way, and this is the next phase. And so there'll be a meeting that'll be coordinated through the Latino Healthcare Forum sometime in December to bring them current. And so with that, I'm going to turn it over to Bob and Tina.
As was introduced, I'm Bob Kallstrom. I'm the project manager for the Southeast Health and Wellness Center project. Have been involved in it since the outset of the planning portion anyways. The purpose of our presentation tonight is to request approval of a construction management at risk services agreement with Bartlett Cock for construction services for phase 1 and 2 of the Southeast Health and Wellness Center. The selection process that was utilized, this CM at risk selection is the third and final step of the Southeast Health and Wellness Center design and construction process. We talked previously about the health consulting. That's been done. The architectural firm selection, that's been done. This is the third part of that piece. The evaluation team for our for the selection of the CM at risk consisted of 5 staff members made up of 2 people from Central Health and 3 people from O'Connell Robertson, our architectural engineering firm. 14 firms submitted responses to the RFP document that was issued to be considered for selection. And I wanted to highlight the broad criteria that were utilized included the corporate experience, the proposed staff experience, ability to manage the construction and safety risk, and ability to establish budget and cost control, pre-construction services, and pricing. I'll talk a little bit about those that may not be real evident what they are. Pre-construction services with CM at risk means that the CM firm will work with our design firm and with us to develop a budget and a plan for maximizing the savings to the, minimizing the cost and maximizing the acceleration that we can get in completing the project. So there are some things that they will recommend that we start early that would save us time. Some other things they may suggest we change to save money. So this pre-construction process involves working closely with our design team and with our Central Health staff to maximize the benefit to Central Health budgetarily and time-wise. As everybody is aware, we have an absolute deadline of getting the dental clinic open in September of 2014 and to have the rest of the Phase 1 project open by October 1st. Bartlett Cock team achieved a composite score which was 33 points higher than the second-rated firm, which was a major gap in all of the scoring of the 14 firms. They stood out quite a bit higher than all the others, and they achieved actually the higher scores of all offers in 3 of the 6 criteria, those being corporate experience, ability to establish budget and cost control, and pre-construction services. Again, the budget and cost control is important to us because we have limited funds available and we want to maximize what we can build. And one way to do that is to save money without reducing value. They also have demonstrated considerable experience in similar size renovation projects and also in healthcare construction. So they have the knowledge and background to work with us on this project. And one thing that was a little, I think is kind of special, is that they presented a timeline that acknowledged the need to have additional interaction for pre-construction. They just didn't blow off the pre-construction services. They emphasized that as an important part of their services. And they would do that without compromising our schedule. And I think that was something that was very important. And lastly, one of the things we'd want to highlight is that they have committed to making a good faith effort towards achieving 13.7% minority business enterprise participation and 13.8% of women business enterprise participation. There's no requirement for that in our submittal, but they expressed their commitment to do that, and they demonstrated where they had done that on some past projects. So we thought that was a benefit.
I truly appreciate that because there are very few dollars that we are able to contract with MBEs, WBEs, so I like seeing that.
Yes,
Thank
well,
you.
we did too.
Thank you.
I wanted to go over the scope of work, what they'll do for their fee that we'll be proposing. The pre-construction services, I've already kind of described that, but I wanted to go over it. They would be working in that capacity for both Phase 1 and Phase 2. The presentation that we're doing today includes CM at-risk services for the entire project. We only have budgeted right now Phase 1, so as we get further along in the project, we'll know better what our dollars needs will be for Phase 2, and so they will work together with us throughout the entire project development. The next step for them, or the next scope, is to develop a project schedule and a guaranteed maximum price for the Phase 1 work. This will tell us the maximum amount that it could cost. If it comes out costing less than that, then we get the savings back. If it costs more than that, shame on them. So it works out that is a guaranteed maximum. Once that is done, they will prepare.
Shame on them in the sense that they pay it.
Yeah.
The next portion of this scope, and this is a real broad category, I'm not going to go into a lot of detail, but they will prepare all the subcontractor bid packages that are then issued for competitive bidding for things like the mechanical system or the electrical system or interior construction or whatever the various subcontracts are. They will be preparing those, and then they will receive the bids, evaluate them, and work with us, make a recommendation to Central Health for approval, and explain why their recommendations are being made. Once that's been agreed upon, they will award the Phase 1 subcontracts, manage the construction and manage those subcontracts, and complete the Phase 1 project construction. The services continue on, as I mentioned, into the Phase 2. They will do the same things for Phase 2 that they do with us in Phase 1. A lot of the pre-construction elements will have already been dealt with, but if things come up or develop during Phase 1 that they can apply in Phase 2, then they would be assisting us with that, again with the bidding and the management and completion of construction. The fee for this scope of services that is proposed is $659,350. And I want to emphasize this is an estimated amount because what we asked them for was one lump sum number for pre-construction services and then a percentage of the maximum construction cost available, the AACC, which I always have trouble with that, which in the RFP was defined as $11.7 million. Now that's construction dollars for both Phase 1 and Phase 2 combined. So those fees that you see there, 2.25% for construction management, based on $11.7 million is $263,250. Likewise, the 3.3% for general conditions is $386,000. This fee amount could change if the guaranteed maximum price turns out to be less than $11.7 million. Their fees would go down on the basis of those percentages. If we approve a GMP that exceeds that $11.7 million, then the opposite would be true. Their fee would go up by those percentages on those two items. The capital budget for fiscal year 2014 for the Southeast Health and Wellness Center project, Phase 1, was $8.2 million. From that, we have already committed dollars for Boulder Associates, and you'll see in a little bit when I go over the timeline, that work has already been completed. O'Connell Robertson has been approved and is underway right now doing the design work. We're in what we refer to as a design development phase. We have a floor plan laid out. Now we're working out the details and how things work, and going through meetings with various providers to verify and confirm the program that we have and to make any adjustments that we need to. The proposed item, excuse me, for Bartlett Cock is $659,350, and I explained how we arrived at that. That leaves available for construction and equipment for the Southeast Health and Wellness Center, Phase 1, a little over $6 million. I'd like to review the timeline going back to the beginning so you have some sense of where we are in the process and when it started. Boulder Associates, our healthcare planning consultant, we executed their contract in early March of 2013, and they completed their planning criteria manual product, which is the basis for the design that's being moved ahead by O'Connell Robertson, was completed and delivered on August 31st of 2013. O'Connell Robertson's architectural design contract was executed on July 18th of 2013, and O'Connell Robertson is currently in process of completing those services, and they will be involved throughout the design and construction phase. They will be working with us throughout the duration of the project. The CM at Risk firm contract was scheduled to be awarded in November of 2013, which we can still do. And some of the key highlights on project development, I touched on it briefly, but the dental clinic, we learned only a couple of weeks ago, we actually have to have patients treated in that facility before October 1st of 2014, sometime in September. And we envision that we can do that. We're making it a requirement that we do that. But then the follow-up, there may be some other areas in Phase 1 that will be completed by October 1st. So it could be a couple of weeks later that we do that. And the final step in the timeline is completing Phase 2. That's currently projected to be completed by October 1 of 2015. So the entire Southeast Health and Wellness Center development will occur by October 1st of 2015. That, of course, is pending funding for the Phase 2 work. We've not presented that to the board or anything. That has not been presented at this point. But we'll have better numbers as we get the CM firm on board. The costing and everything that's been done so far has been done in-house based on past experience. The next steps, if the board approves the contract to award to Bartlett Cock, first step is to execute the contract and get them started. They will be contracted to do their services for both phases, recognizing that Phase 1 is absolute and we're going ahead with that. Phase 2, the scope of that may change based on budget availability and so forth. But we wanted to have and are recommending in this contract to have the same construction management at risk firm involved throughout the project. It will make for a lot smoother operation. Hopefully we can even maintain the interest of some of the major subcontractors so we keep the same team together from beginning to end. We feel that that will decrease problems as the project develops because everybody knows what's going on. And then the CM at Risk firm, once they're hired, will develop schedules and guaranteed maximum price figures for the construction of Phase 1 and Phase 2 that meet the requirements established by Central Health. Those requirements are schedule and budget. And so they'll be working closely with us and our design team to address the requirements that we have financially and schedule-wise for the Deseret projects. And just as kind of a summary for everybody as I close, Phase 1, I wanted to tell you and emphasize what's included in Phase 1, and I know the community will be seeing some of this when we do our presentation in December. Wanted to share with you that Phase 1 component includes the primary care, one primary care clinic, a specialty care clinic, and a mental health clinic. The primary care clinic is going to have 9 exam rooms and a flex exam, plus procedure rooms and other support functions. So it will be larger than some of our smaller clinics that we operate right now, and smaller certainly than some of the others, like North Central is much larger than that. But we'll start out with a good chunk of primary care. Phase 2, the other thing is the dental clinic. I always seem to miss that for some reason. Don't like going to the dentist, I guess. The dental clinic is included, and an initial quantity of community access space. The community during the planning phase had requested the ability to have space that they could utilize for functions of their organization. Basically, they need a place to meet or a place to hold an event. And so we have accommodated in phase 1 a large room, basically, that would be earmarked for that use initially. Essentially, it will end up being a large space that is just enclosed and finished out that would be subject to change in phase 2. Phase 2 includes 3 additional primary care clinics, each one of them mirroring the size of the first one. So there would be 11 treatment areas plus a procedure room in each one of those additional clinics. Along with that would be radiology services, 2 radiology rooms and 1 mammography room. There are 2 also ultrasound units that will be embedded in the clinic pods themselves. They won't be a separate room in radiology, but the equipment will be there. Laboratory, and this laboratory is going to be different from most of the labs that we have in our other clinics in that it will be a full service lab. So the intent is for patients arriving at this center, this clinic, if they need any kind of a lab test other than something really specialized, but normal routine diagnostic test, the intent would be to have those done at that location. So it's not that they give their blood specimen or the urine specimen and it gets sent off to LabCorp down in San Antonio and comes back a week later. The intent is to have that go across the hallway, be analyzed, and the results come back before the patient leaves. So that is the intent. We have not designed the internal workings of the lab, but that is the program concept. The pharmacy that's going to be incorporated there is the pharmacy services currently operated by Community Care on the 5th floor of the RBJ building. And because it will be there, it will also facilitate some delivery of prescriptions directly. If they're ordered, they'll be right there in the location. So the people coming here to this location that get a prescription may be able to get it again by just crossing the hallway and going to another part of the building. That is the intent. Along with that is a navigation and eligibility services area to help people. I can't get into all the details because I don't fully understand all the workings of that system, but that people will be able to figure out where they need to go to get all the services they need. They will be assisted with that on site. So that will help tremendously also. Along with that is the balance of the community space. A WIC program space is being programmed in the City of Austin. In fact, I have a meeting on Friday morning with the City of Austin WIC program to go over their area. Facility administration, both clinic and if there are any general administrative duties to operate this whole facility, we'll have administrative space for that, and facilities and building support space, which will include things like mechanical rooms and equipment and so forth, and the facilities management department of Central Health will relocate and be housed in that area. It's convenient to downtown, and it also would then be convenient to one of the largest building that we will have in our system. That's kind of it in a nutshell. I'll certainly try to answer any questions that I can.
Okay, questions or comments? Katrina, do you have, okay.
I have a comment and a question. We discussed this item in Budget and Finance and approved it, but I had a question that I didn't think of in Budget and Finance. On slide, what slide this is, 6, I think it is, award estimate. You talked about the construction management fee and the general conditions fee as being a % of the amount available for the construction contract in the RFP. And so when we approved this item in Budget and Finance, we set an amount not to exceed the recommended, staff recommended amount. So I'm guessing if we exceed 11.7 million in the available amount for the construction contract, then they'll have to come talk to us again, right?
Yes, yeah, in some fashion. Now, I guess because part of that 11.7 million involves fees that might be less, but the construction dollars might be more. If things change, the total cost would not go up.
I see.
Yeah. Now, if it does, then, yeah, we're going to
We'll
have
have to
to,
talk about it
if
some
we,
more.
yeah, we'll have to talk about it more internally and at the board, I'm sure.
Okay.
May I?
Yes, yes.
Thank you, Madam Chairman. What is the projected annual encounter capacity for this new facility?
Well, that's kind of out of my realm, but we would have 12 times 48 plus 452 plus some mental health. We'd have 52 treatment spaces, not including lab and radiology. I believe that the turnaround, I haven't done the math, but I think the turnaround that community care operates under is about 45 minutes on average. So however many exam rooms that is per day, it's larger than most clinics. The total number of exam rooms that are out here is actually less than what's at North Central.
Just let me tell you where I'm going with that. You mentioned that the laboratory, lab, pharmacy, and navigation eligibility services will be available. And we want to provide, to the extent financially feasible, full services. And that we're providing radiological services as well, which would be limited to X-ray and sonography, correct? Have we considered CT and MRI? Because there are providers that the technology is not as expensive, but not as expensive as it used to be, and there are clinics that have their own CTs, for example, on-site, and facilities are much smaller than what this facility will be when it is open.
That was discussed during the planning exercise, and I wasn't the one that made the final decision, but the direction that we got from the input during planning was that the volume of those services for this area would not justify having CT scan or MRI at that location.
Okay.
Now, I don't understand all the demographics and data, but that was discussed, and we decided to go with the basic X-ray and mammography.
I don't understand it either, but if it was discussed
Yeah.
and prudence dictates to the contrary, that's fine with me. Thank you.
Anybody else have any other questions or comments? This is a recommendation coming from, well, Budget and Finance.
You want me
So,
to make a motion?
yes, please.
I move that the board approve an agreement with Bartlett, Koch General Contractors for Construction Manager at Risk Services for the Southeast Health and Wellness Center in an amount not to exceed $659,350 as presented by staff, and authorize Central Health's President and CEO to negotiate and execute a final agreement on terms similar to those presented or on terms more favorable to Central Health.
Thank you for that motion. Since that's coming as a recommendation from the committee, we don't really need a second on that, right? Okay, so further discussion. Lynn, did you have a question?
Yeah, just a quick summary question. We're using 11.7 million as the amount at which we're matching those percentages. So, but the 2014 capital budget for phase one is 8.2. So I'm assuming that the remaining amount, 11.7 minus 8.2, is phase two costs?
No, the phase two cost, the 11.7 includes only construction dollars. It doesn't include the other costs associated with equipment and so forth. So the 6 million, the 8.2 million that's funded would build phase one construction, plus we would have $6 million left to build it. We pay the fees out of it and we get the equipment, so we would have a complete phase one for the 8.2 million. If we go on to phase two, there would be additional funds required, and that would have to come back before the board for phase two funding, and I think it would be in the fiscal year 2015 budget. Yeah.
Okay,
So
Okay, so the 11.7 is a number that we started with, and that represents the building and equipment?
No, just the building construction.
Right.
Because that's basically what our construction management firm's fees are driven by, the cost of construction. So their fees include, their fee includes the construction of Phase 2 at, you know, I think one was 5.6 for Phase 1 and, or somewhere in that range, and the other was 6.1 total construction dollars, including fees. So their fee, we're assuming they're going to continue on and will be doing Phase 2. If Phase 2 ends, then the dollars won't be spent, then their fee would inherently, if for some reason Phase 2 got canceled, which I certainly hope doesn't happen, then there would not be any construction and there wouldn't be any fees associated.
I'm sorry that I keep just beating this. I still don't understand the 11.7, what that dollar amount was.
That dollar amount was the budgeted construction dollars only for Phase 1. There was approximately 5.6 million, and then the budgeted construction dollars only for Phase 2, which was roughly 6.1 million. So the two of those construction figures together is 11.7. The project was broken into those phases due to budgeting, and so that's where we only funded the first phase at this point.
Thank you.
But you take the 5 and then all those other costs, and that's
Okay.
the 8.
Okay, then we got it.
Okay, any other questions? We do have a motion on the table. Ready to vote? All in favor signify by saying aye. Aye. Any opposed? Okay, thank you. And do you want to introduce the people here from Bartlett?
Tina, you-
Sure. We have two gentlemen from Bartlett Cox here. I'd like to introduce you to. If you would stand up, please, and then introduce yourself.
Hi, I'm Kevin Byrd. I'm the Vice President for our Central Texas office here in Austin. We've been here for about 15 years. It's kind of intriguing to listen to all the great things you guys are doing in our community. I feel like our values really align well because we specialize in building buildings that serve a higher purpose in our facility. So we're very happy to be a part of this project.
Thank you.
My name is Scott Stites. I'm the pre-construction services manager for Bartlett Cox. I've been here since '91. I'm more used to seeing Tom coop wood, chopping weeds at Fiesta years ago. In White Paula with some of our first friends in Austin when we moved here in the early '90s, and we're very, very excited to serve Central Health.
Thank you. Welcome. Okay. It's 7:49. I'm going to take a 6-minute break. Okay? Back at 7:50. Did we?
No, we didn't.
We voted, didn't we? Oh, God.
Yeah,
Yes, we voted.
We did.
Yes, yes. 7:55, okay?
It's all a blur.
I know it is. Yes.
Embarrassing.
Okay, let's go ahead and get started again, please. I actually gave you a couple more minutes. Okay.
You woke up.
Number 6, discuss and take appropriate action for the purchase of computer hardware and related services for Central Health and affiliated entities to be funded by fiscal year 2014 Central Health capital funds.
Thank you, Jeff Knodel, Central Health CFO. This item was presented at Budget Finance and was recommended for approval to the Central Health Board. I'm going to go through it fairly quick. Feel free to ask me if you have any questions. So the background of this item, there currently are some shared servers used by all 3 entities, Central Health, Community Care, and Sendero. And those servers came from the city in 2009 during the transition of Community Care from the city to Central Health. So it's fair to say the servers are at least 5 years old, and I would venture to guess much older than that. The issues, again, the servers are old, they're past their life cycle, and they need to be replaced. And most importantly, it's very critical for Community Care to initiate the replacements immediately, as they are required to convert to a coding, procedure coding called ICD-10 by September of 2014. This is the coding required for the provision of services, certainly to be paid, certainly from Medicare and Medicaid. And it's a very big initiative that's been out there. And I think it's a very challenging initiative for entities to convert to ICD-10. It also offers an opportunity to bring new server technology to help manage our IT resources more efficiently. In other words, newer technology at this time, supplanting older technology, allows us to leverage the technology to be more efficient. The timelines for the server replacement, and again, it's driven through the need for the ICD-10 conversion from Community Care, is to install the hardware by early January 2014. And as part of the ICD-10 conversion, or the implementation of that conversion, which is required to be completed by September 1st of 2014, is that we're going to have to do a minor upgrade and a major upgrade to NextGen, their clinical system, in order to accommodate that conversion. So the cost information on the servers, the hardware, and the installation is for an amount not to exceed $280,000. The funding source would be the Central Health Capital fiscal year 14 budget. And you'll see here that we have a beginning balance of $6.6 million plus an additional $4.5 million from operating funds, bringing us to $11.1 million, less the phase 1 budget for the Southeast Health and Wellness Center. So we have an available budget of $2.9 million. This proposed item would be $280,000. So our recommendation, staff's recommendation, is to approve the item to authorize the Central Health President and CEO to execute the contract in an amount not to exceed $280,000. And that would be, again, for both hardware and installation services. Again, this is a real time-sensitive issue. I think it's real important that Community Care begin work immediately on the ICD-10 conversion. So I'm bringing this to you as quickly as we can.
Okay.
So I'll certainly answer any questions.
Appreciate that. Katrina, is this something else that came to your Budget and Finance Committee meeting yesterday?
And we voted in favor of the staff recommendation.
Okay.
Recommending that to the full board.
Okay. Can we get a motion?
I'm happy to make a motion.
Okay.
I move that the board approve the purchase of computer hardware and related services for Central Health and affiliated entities to be funded by fiscal year 2014 Central Health capital funds in an amount not to exceed $280,000 as presented by staff, and authorize Central Health's President and CEO
to negotiate and execute final agreements on terms similar to those presented or on terms more favorable to Central Health.
Okay, thank you for that. And again, as that's coming from the committee, does not need a second. Discussion. Anybody have any questions? Anything else on this? We good? Okay. All in favor signify by saying aye. Aye. Any opposed? Okay, thank you. Okay, on to number 7. Receive and discuss a report of the October 2013 financial statements for Central Health.
Thank you, Jeff Knoebel, Chief Financial Officer. With me is Rosie Vela, Controller. And I'm going to go over the financials for October fairly quick. It's our, these are the financial statements for Central Health. It's the first month in our fiscal year, so the first month of 11 additional months. So up on the screen, you'll see the, oh, I'm sorry. Right here? Oh, yeah. Okay, sorry. There we go. Sorry about that. So I'm going to go through this quickly. Again, this is first month, October, as of October. So beginning with lease revenues, we received $2.7 million in lease payments from Seton in accordance with our lease agreement. And again, this is just the first month and represents 9% of our budget. Healthcare delivery expenses, $21 million in October, or 13% of the $155.9 million in annual budget. We had 2 IGTs, intergovernmental transfers, in October. We had a disproportionate share intergovernmental transfer of $16.2 million. And then we had a real small DESRIP intergovernmental transfer for a project being performed at Bracken Ridge, and I believe it was related to their psychiatric emergency department. So they had performed some of their metrics in an August reporting period. There was a very short window for some early reporting, and so they met the requirements of that, and we did an IGT, an intergovernmental transfer in October for that. So salaries and benefits were $494,000 for October. Other purchased goods and services were $358,000 for October, with 7% of the $5 million budget. And then depreciation expense was $292,000 for the month. Non-operating expenses, our primary revenue, net property tax revenue, collections were $1.9 million in October, or 1.4% of the $139 million budget. And again, property taxes for fiscal year 14 aren't due until, typically we see a strong inflow in December. Technically, they're not due until the end of January, so we should see that pick up as we get into a few months down the road. The property taxes do reflect the 12.9 cent rate that was approved in Proposition 1. Our tobacco settlement, we haven't received any. We don't file our tobacco settlement until the end of March of 2014. Investment income is $28,000 of our $400,000 budget. Interest expense related to our certificates of obligation, we accrued $38,000 related to those debt instruments. And then our issuance costs, we've had a new GASB that we're implementing in fiscal year 13. Previously, we had amortized those over the life of the debt. We've implemented that, and we're recognizing that full amount as of September 30th, 2012. So this, for the month of October, we have a decrease in net assets of $17.6 million. Let's see, let me get to the balance sheet real quick.
Seth, may I ask you a question? The investment income, does that include the investment revenue, my portfolio?
Yes, that's actually what that is.
The numbers are a little different. Is there a reason?
The investment,
Yeah, the investment revenue is 28,946.67.
no, it's on the front page, it's investment income, 28,000.
Oh, I'm looking at total
Under the
revenue.
second,
Okay.
yeah, it would be the second column.
Thank you.
Sorry.
Okay.
It's different from mine. What did you do to the-
I'm going to go ahead and get started on the balance sheet. Again, it's the first month of the year. Our cash balance is $120,000, which again is just our operating account. Short-term investments, again, are at $98 million. We have an investment amount restricted for future Sendero paid-in capital of $15 million and an additional $6.5 million restricted for capital acquisition. Our ad valorem taxes receivable is $137.8 million. And again, this is, we're in the very beginning of our new fiscal year, and we would expect to see a very large amount reflective of a receivable for those property taxes. Our other receivables total $619,000, and they consist of mainly a variety of just some intercompany receivables and a few small receivables. Prepaid expenses of a balance of $619,000 include, the standard stuff that we've been amortizing over a period of time, including the mobile mammography van. We also have some prepaid expenses, some smaller amounts in that. On to the non-current assets, cash and investments restricted for capital acquisition, $6.5 million balance consists of $3.4 million in short-term securities and $3.1 million from our Series 2011 Certificates of Obligation construction account. Again, we have the investments restricted for future Sendero paid-in capital, which is unchanged, $15.1 million. Our paid-in capital, which is unchanged, to $14 million. And then our working capital advance to community care, which is also unchanged, to $4 million. Total assets of $370 million. On to liabilities. On our accounts payable, we have a balance of $11.9 million. And let me go through some of the components of that. There's $1 million due to Seton for our fiscal year of 2013 tobacco settlement. $4.3 million is due for charity care. We have typically in the past paid charity care, or charity care has been budgeted in Central Health. We will continue to budget for charity care in Central Health. Per the master agreement, though, the payment will come from the CCC. So we will be sending the money over to the CCC if that's from a master agreement requirement. The money will come from Central Health to the CCC and paid from the Community Care Collaborative. There are $1.6 million due in vendor invoices and $700,000 in estimated cost incurred but not yet reported for healthcare providers, or what's known as an IBNR. Salaries and benefits payable of $542,000, which is an estimated liability for salary costs not yet paid at month end, plus the value of our accrued leave balances and fringe benefit amounts. Debt service payable, a short-term amount of $996,000, and the principal is due on March of 2014. deferred tax revenue, which is, of course, the offset of our property tax receivable of $137 million. And then we have a other deferred revenue amount of $2.7 million, and that reflects a lease payment that we received from Seton in advance. It's the November payment, and we actually received it early, so we've not recognized the revenue. We've recorded it on the balance sheet. That amount in November will move over to our income statement. So it was just an early payment. And that brings us to total liabilities of $164 million. Our net assets, unrestricted net assets of $89 million. Total net assets of $207 million. Total liabilities and net assets of $370 million. So be happy to answer any questions anyone has on our October 2013 financial statements for Seton Health.
Thank you. Any questions or comments? Yes, Kirk?
What is the basis for our debt service obligation?
The basis of our debt service obligation is related to debt we've issued and a debt repayment schedule that we pay principal back on.
It's North Central Clinic.
Thank you.
Oh, I'm sorry.
And the Southeast.
Southeast
Oh,
Health and Wellness.
Okay.
Oh,
Yes.
sorry, misunderstood that.
Yes. Okay.
All right, thank you.
Thank you. Okay, number 8, receive and discuss the CEO's report on the following central health activities. A, procurement activity. B, current communications outreach statistics. C, eligibility services. And D, the Community Care Collaborative, including medical access program enrollment and activities. Mr. Wallace.
It's me again, and I'm going to be very brief, and I'm splitting this presentation or report with Christy. She's going to cover the communication and outreach. In your packet, you have your procurement activity report, which reflects contract actions greater than $25,000 from October 6th to November 6th. And we would ask that you review these contractors, look at the new vendors, and if you will, follow your conflict of interest policy. On the second page, the new contractors are listed there for your reading. And it also denotes which of those are HUB certified contractors.
Larry, down at the bottom of that first page, I can't remember what NTE is.
Not to exceed.
Oh, okay.
And the only reason that's there is I think the not to exceed amount changed. It was previously $486,651, and so it was increased to $540,198.
Larry,
Yep.
yes. Second to the last entry, Cope Health Solutions,
Yes,
$60,000.
yes.
Is that an additional payment to our Cope Consulting Group, or is this a different Cope?
It's for the anchor.
Let me answer
All right.
that. It's a small contract. We, as the anchor entity, have some anchor responsibilities to inform learning collaboratives. There's a tremendous amount of money related to those learning collaboratives. There's deliverables in a lot of Desert projects, not only for us, but other providers in Region 7. So they have some learning collaborative expertise. We contracted with them in very short order in order to hold those region-wide learning collaboratives. And so it was, the contract was actually to have, I think, at least 2 or 3 sessions if needed over the next year.
So just to keep track, we have 5 contracts.
Yeah,
with Cope.
I realized at some point I left this one off.
Okay.
It is reimbursed. This amount is reimbursed as the anchor entity.
Right.
We do get reimbursement for it.
Thank you.
Any other questions on procurement? Yes.
I'm sorry, Larry, to ask, but all these, the top ones, the PR, the Han Public, Communications, Yates Consulting. They're all total not to exceed 225?
That's correct.
Are they all working together on one project?
I don't think so, but I'll let Christie address that.
They're a pool of services. They're service contractors that are available for us to use. The
Uh-huh.
total contract, the total amount that Christie can spend on these services is 225.
Okay, I mean, but Belmont Ice House is probably different than culture. Are these the ones that we're doing, Christie, now with the
So-
new projects? I mean, the
so
new funding?
These vendors were selected through a process that we went through in order to have a cadre of vendors on hand for communication projects throughout the year.
Just to have in your back pocket?
Yes, so
I
we
got
wouldn't
you.
have to go, so we could enact things quickly
Gotcha.
and easily. So some of them are going to be
Okay.
vendors involved in the
Okay.
public information campaign,
Okay.
some will not.
Okay,
Mhm.
so you just don't have to go vet them all over again?
Correct, it
Thank
allows
you.
us flexibility.
Thank
This
you.
is the retainer then?
It's not a
Not to exceed.
retainer. There's no financial commitment until there is a scope of work that's
Good.
agreed upon.
Okay. Thank you.
Any other questions? Okay, and I'm going to cover the Community Care Collaborative report, and it's very brief. Just in what we had talked about in our board meeting yesterday, the approval of the CCC strategic plan, and there was some recommendations to make adjustments on some of the measures. We talked about the Demonstration Year 2 CCC Delivery System Reform Incentive Payments Project Reporting. We also approved a application for the DY3 CCC DISRIC project implementation contracts. And we also approved DISRIC Year 3 CCC DISRIC project implementation contract template. And I think you'll hear more about that later. And then the very last one was the DISRIC project consulting services with COPE that you just heard about. And the last report that I'll touch on, because we'll come back next time and give you an update on the activities around outreach and education. Michelle has that report, but we'll bring it next time.
Can you share the strategic plan with us, or should I just go online to find it somewhere?
I think.
We're going to have a report on that
Yeah,
just
you're gonna-
Tonight?
you're
Oh,
gonna get
okay.
that.
just a brief update.
Right.
Thank you.
And the last report is on your MAP enrollment.
Mhm.
And so, yes, sir.
I got a question about the MAP enrollment. You know, it's going up nicely now, and it's, what, 24? And when we hit 25, what happens?
Well, really, when we exceed 24, based on our new agreement with the CCC, we need to have a conversation. And so this is one of the items that's really being taken up with our advisory committee, which is made up of the Seton and our own staff, when we meet every Tuesday morning at 7 o'clock a.m. Christie wanted me to say a.m.
Yeah, she likes that early morning.
Yeah, but that's a component in the agreement that we're going to need to talk about. But I have to say there are lots of questions that we have already discovered as we begin trying to figure out what does this 24,000 mean? Because as you know, Dr. Cootwood, because you have people enrolled, they don't all use services. So we have to really drill down and look at utilization, and that's going to be a basis of quite a bit of work that we need to do at committee level, and we'll be bringing it back to you.
So we won't, just because we're up to 24 or 25,000, we won't stop adding
No,
MAP patients?
no.
people
And
that are
as you know,
available?
this number, it fluctuates. And this isn't, even the November number, it went down a little bit. So, but no, we're not going to, at this point, do anything different.
So we'll keep signing them up if they're eligible.
We'll keep doing what we're doing until we decide to do something different. And when we do that, you'll know it. Okay, any other questions on these reports? And I'll turn it over to Christie.
I have one. Just what are unique visitors to the website? Who are they?
Who are they?
Unique visits to the website.
Unique visitors.
Uh-huh.
Unduplicated?
Is
You
that
want
what
to think
that
about
is?
it that way? It's like an
Yeah.
individual that visited the website.
So if I went there 10 times, I'm
You
one.
would be counted, if you went 10
Oh.
times, you'd be counted one time.
One time.
Yeah.
Yeah.
Thank you.
Okay. Sorry.
No.
I did know the answer to that question. I just didn't understand the question.
I wasn't trying
I'm
to throw you a
sorry.
curveball. I'm trying to absorb the information.
Okay.
Thank you.
I love the word.
So on the communications and outreach report, and Ellen, would you step up here for a minute, because we're going to talk about the strategic plan briefly as well. So just to highlight, we have been out there quite a bit, giving presentations on a variety of topics. So we've been in front of 874 people in the last month, which is, I think, probably a record for us, or close to a record. And we did host Secretary Sebelius here on October the 25th at the Community Care East Health Center. It was a very successful visit for us. So those are the highlights on your communications report. Mr. Kirkendall has already identified some of the statistics on the website. Statistics, our websites were, well, 4 of our websites were down today unexpectedly for a short period of time due to a crash at our hosting site, HostGator. So, but they were back up within about an hour, I think, was about the time. So.
If I could just say something a little humorous, I think I have reached the pinnacle of my career, because I actually showed up on the Jon Stewart show with Kathleen Sebelius.
That's right.
I think I've hit the top. And I think there's no further I can go.
And we're proud of you.
I know. It was awesome.
Did
it
he
was,
insult
it was
you?
a brief half second of fame, but
It's
it was
fame,
real.
nonetheless.
Well, I think that
all the national TV
I was on
channels.
all the
Fox
national,
especially
Fox,
shows you a lot.
NBC,
Yeah, you-
the Today Show, the Morning Show, and then Jon
Jon,
Stewart.
all
I mean,
right.
tops it all.
Wow.
You and the secretary definitely made the rounds.
We did, yes.
I'm going to need your autograph.
I know. I know. It was really, I had to text, when I saw that, I had to text my son, I was on Jon Stewart. Check it out.
I do recall the time, though, you did that live interview with Fox News, though.
Oh, that was horrific.
Yeah, that was really a challenge. Okay, and so actually Ellen is here not to talk about the Central Health Strategic Plan, although we can give a brief update on that as well, but also to preview the Community Care Collaborative Strategic Plan process. That's fine. You can do it. So Ellen Richards, Director of Planning for Central Health. I've been working for the last many weeks with Beth Peck, who you may recall, and with Teresa Griffin from Seton on the development of the CDC strategic plan. We have finished the final plan through the strategy level, and took that yesterday to the CCC board for review and approval. And they have given it conditional approval for it to come forward to this board next month.
Okay.
And so we will be presenting that on at the meeting on 12/11. And we will be sending it out in advance so that you have an opportunity to review it. It is dense, as you can imagine, with like 30-something strategies in it, so we won't exhaust you by going through those in detail next month, but we will give you an opportunity to review it ahead of time, and I'll even see if we can't send it out a few days earlier than the normal packet so that you'll have plenty of time to thumb through it and then ask any questions and give us any feedback or address any concerns that you have. So I just wanted to kind of warn you that that was coming and where we were in the process. So what you'll see next month will be the vision, mission, values. It follows the same format as the Central Health Strategic Plan: foundational elements, goal statements, and strategies. We will be working on measures and bringing those back at another time. And in terms of the Central Health Strategic Plan, we've finally gotten the final version completed from the graphic designer, and so we'll be getting that posted. I think it may already be posted on our website, but we'll be getting that distributed as well here in the next week or so.
Okay, Thank you all. Yes, questions, comments?
So all the things in our packet that deal with marketplace, public information, we're going to talk about next month? Yes. Next month, everything next month. So I get to zip all my questions.
Right
Agenda
there.
item
10.
I won't.
Okay. On to number 9 then. Receive and discuss reports from the board committees, Budget and Finance.
Madam Chair, the Chair of the Budget and Finance Committee meeting, Ms. Katrina Daniel, had to leave and has asked me to give an update on what transpired at yesterday's 2.5-hour Budget and Finance Committee meeting, most of which came before the board this evening. And above and beyond what, well, let me mention this. The presentation that Southwest Retirement Consultants provided and Branch Banking and Trust, BB&T, was on the consent agenda, but I want to assure, particularly the employees who are either in the 415 plan or 457 plan, we did have a fairly good discussion about the implications of that. Likewise, we had a very good presentation from Community Care on their fiscal year ending 2013 results, which are still subject to audit, but a very good report. Looking at what has not come before this board. Everything else has come before this board. So that is, if you will, the full agenda of 2.5 hours worth yesterday of Budget and Finance.
And a real long one from Sendero, too.
I'm sorry, thank you very much. And a very good presentation from Sendero on a host of fronts relative to marketplace as well as overall operations of Sendero.
Okay, thank you. Ad hoc nominations committee.
Ad hoc nominations committee met today at 4:15 to discuss a proposed slate of officers for Central Health for fiscal year for calendar year 2014, and that will be brought to the entire board at its December 11th meeting for discussion and action.
Okay, thank you. And then the performance improvement subcommittee. Who was at that meeting? Tom, will you take that one? Or anybody else want to take it?
I don't remember.
We again had different provider groups come and sort of speak about their production of the data about metrics we're concerned about. And this time, I think, wasn't it, Tom, that was Lone Star that came and spoke? So performance improvement is just moving along with its stated goal, which is to design metrics, have contractors or providers report on them. And what we see every day, and I think Katrina would want this spoken about, that what we're doing is kind of good homework for the CCC in terms of establishing a base of expectations of performance that the CCC will build on and probably build out and make even more elegant and more sophisticated.
Thank you for that, Lynn. Okay, number 10, discuss and take appropriate action on Central Health owned property, including University Medical Center at Brackenridge and adjacent properties. Hi, Mr. John Stevens. How are you?
Good, thank you. I'm John Stevens, the Director of Financial Planning and Management for Central Health. And I'm here this evening to give you just a brief update on where we are. We've actually only started our planning efforts. As you know, I've been working on them for about 8 weeks now. But Trish and I had an opportunity last week to attend a breakfast that was hosted by the Downtown Austin Alliance, where we heard a very good presentation from 2 guys who are working with what's called an innovation cluster in Cambridge, in Boston. And there is a lot of interest, I think, among a number of stakeholders to try to sort of replicate that here if it makes sense to do so. And so what I wanted to do tonight was just kind of walk you through our understanding of what that would involve right now. It's something that you'll be hearing about as we go through the reuse process, and ideas hopefully surface about how we might synergize or maximize the use of both our space and the other things that are going on in the area down there where the new teaching hospital will be built. And then I'll just give you a quick update on what else we're doing. we are new to this endeavor. I think everybody involved in it is new to it. So it's something that has been done in other places, but we're ultimately going to have to figure out how to kind of do it as we go along. But the presentation will deal with just first of all, what is an innovation cluster? Who's in the Innovation Cluster Advisory Group? This is a group that the city mayor has formed, and we'll tell you who's involved in those efforts. Talk a little bit about the goals and objectives of the group, and then talk just for a moment about issues and stakeholders. Anytime you have a big project like this that involves real estate development, you've got a lot of different perspectives on what needs to be done and who ought to be doing what. And so we'll talk just a little bit about that. So what is an innovation cluster? It's a geographical area where knowledge and talent are concentrated. And these remarks, of course, are coming from the two guys who gave us the presentation last week and then met in the mayor's conference room with us and the people who are going to be working in this group. It's an area where proximity and personal relationship help reduce friction and compress time. It's a way to get smart people in a room who are all working on trying to do things, some of which are related and some of which may not be. It's a place where information and ideas flow freely through relationships of people and institutions, and it's a place where community values are enhanced by the cluster. This is another way of looking at it a little more detailed, and these are what they called the self-organizing elements of a successful cluster. So you start out with the geography. You've got a place where people are coming together, where these elements are coming together, and then you see the other parts that make up a successful cluster. The mass transit, I'm not so sure about. I don't know that that's an absolute requirement. It's certainly one that's happened in Massachusetts, and it's happened likewise in Silicon Valley. Then you see financial capital, of course, very important. Knowledge capital. A number of these types of places, these types of clusters, are centered around major universities, Stanford, MIT, and so on. So that's the knowledge capital part of it. The cultural arts, I think, sort of goes along with that. It's associated with the folks from the university and the other members of the community who value that sort of thing. And then very importantly, you've got what they call the founderati. You've got entrepreneurs, and these are people who may be actually investing, in some cases investing venture capital in these projects, but in other cases they may simply be acting as mentors to some of the people who are working together to try to make things happen. And then you've got developable space, and I think this is one of our potential contributions when we look at UMCB reuse. We don't have a lot of ability to expand horizontally on that campus, but there may be opportunities to expand vertically, for example. And so to the extent that it fits in with the board's objectives for the reuse of the property, we would try to work with the other folks in the Innovation Cluster Advisory Group to see how that might be done on our end. This is sort of a more concentrated way of looking at it, kind of the same thing. These are the 4 key institutions that enable these clusters to form. And one is the academic side of it, which of course, again, in the Boston examples that we'll look at in a little more detail in just a moment, involve MIT. Here, of course, it's UT who would be the player in that. In California, it's Stanford. In other places, it's other major universities. Government plays an important part in this effort too, because in some cases, government may provide funding, either funding for startups or something like that, but governments also play a very important role in addressing quality of life issues. In other words, trying to form communities and build infrastructure and provide opportunities for people related to the quality of life. An example of that would be a lot of money that they spend in Boston, for example, to clean up the Boston Harbor. And one of the clusters that we'll look at is right there on the harbor. So we've got two examples. Both of these are from Cambridge. One is called the Cambridge Innovation Center, and so this is actually an example of the type of activity that might go on and how people are going to work together in one of these innovative clusters. This is not the cluster itself, but this is an outcome of that. You've got the Cambridge Innovation Center that is located in two buildings owned, they're owned by MIT, so you've got the university involved in that. They're in Kendall Square in Cambridge, and those two buildings provide infrastructure to house startups who like to be close to other startups. I looked at the guy, I can't remember his name now, anyway, the guy who owns those buildings and is leasing, or uses those buildings, is leasing the space out, and he talked about how valuable it was for people even to be on the same floor. I mean, you would think in a high technology era and in a high technology environment that there'd be a lot of communication done, and there probably is a lot of tweeting and all that stuff. But nevertheless, he was adamant that it really was important for people to actually be close together, where they just kind of congregate naturally and talk about what they're working on. So with the Cambridge Innovation Center, you see there have been over 1,500 enterprises created since 1999, 40,000 jobs created, and $8.7 billion in venture capital. And I had to, that's bigger than the number we saw at the Downtown Austin Alliance breakfast. And I had to play the tape again to make sure he was saying that, and he did, 8.7 billion. So here's another example. It's called Mass Challenge. It was founded in 2010 by John Harthorne, who left Bain Capital to do something that he had always wanted to do. And so what he did was he got a floor on a high-rise building that a developer had built on the newly renovated Boston Harbor. He got that space dedicated to him, and he uses it to provide 100 startups a year with a 4-month accelerator program where somebody comes in with an idea, they compete in order to get into the mix of the 100, and then once they're accepted, they have a whole host of mentors that work with them to try to take their idea as far as they can. And then at the end of the program, depending on how successful they are, some of the startups are then awarded grants to continue their work. And so they have raised so far $362 million in funding. This is just a partial listing of the people who will be members of the group that we will participate in. It's the Greater Austin Chamber, City of Austin, Downtown Austin Alliance, Seton, St. David's. Interestingly, the Texas Facilities Commission will be participating, possibly, I guess, to look at the redevelopment of some of that property where there are garages there near the Irwin Center. UT Austin, of course, Travis County, and the Waller Creek Conservancy. I'm really delighted to be working on the Brackenridge Reuse Project. It connects up to my past history with the city, because the last year I was there at the city, the Waller Creek Project was the one that I spent most of my time on.
So John, is Central Health a bullet that's going to be added to this list
yes,
then?
we are implied as a bullet.
Okay.
Yeah,
Okay.
sorry.
And does that mean you'll go be all together in some room or some building and be innovative and pass ideas back and forth?
I'm not exactly sure how it's going to work out. What it means is that you'll see the goals and objectives in just a moment, and we'll talk about what we're going to do. But the people who are members of this group will meet, I don't know how many times, I would guess 10, 12, 15 times over the course of the next year. And when we look at the objectives, I think it'll hopefully become more clear about what we're trying to do.
Okay.
But we will ultimately, as a group, come up with a set of recommendations to make to the larger, to all of the other people who are participating in this. Part of the urgency for us is really just time, because there are a lot of things that are happening right now that are, closing in on that property around where the new teaching hospital and the medical school are going to go. The goal is to create a shared vision of an Austin Innovation Cluster and identify appropriate recommendations and vehicles for implementation to achieve that. And the objectives are these. That first bullet describes what I would call as the micro objectives, and that is just to inventory these things, the state of all current and prospective resources, plans, opportunities, and so on that might contribute to an innovation cluster. That's again kind of the micro. What have you got down there that could be worked with? Then the second bullet is more the macro, which is analyze emerging trends, economic opportunities, urban planning, and so on. In other words, to take those micro components and try to, based on what we know is going, the direction that things are going in, to match all of those things up and see if they make sense. And then participate, lastly, in this strategic visioning exercise to figure out what our priorities would be here in Austin for the Innovation Cluster, and to create a set of recommendations and vehicles to implement. One of the things that we're trying to be mindful of is we want to put forward recommendations that are not only pragmatic and achievable. We'll do the visioning and we'll try to make them as bold and as innovative, I think, as they can be. But we also want to try to come forward with things that we think will have a possibility of success, so that people will understand how to keep a sustained focus on keeping those recommendations, those objectives going. Here are the potential stakeholders that are involved in some of the issues. These are really just sort of complicating factors about the reuse of the project. So now we have this Innovation Cluster Advisory Group who's going to be interested in what we do with the Brackenridge campus. In addition, as you guys have heard, there's going to be a realignment of Red River done to the north of 15th Street that will go through the UT campus. It'll be a 3-lane realignment of Red River. Interestingly, it's going back to the alignment that it had in 1976, the original realignment. And so I think there's going to be interest in having that come south of 15th and go through the campus, between the parking garage and the main tower. And so I've had a couple of conversations with people at the City Department of Transportation Planning. I'm going to try to get out as soon as I can with them to figure out, exactly what the effect would be, if any, on the structures that are there, where that realignment would go. And then we'll have to try to figure out how we would be compensated for their taking that right of way from us.
For that realignment, did we vote for that? Did we want that, or is that something the city just said we want to do?
It was
The university said you had to.
Yeah, in order to,
Yes.
to obtain both, or the new teaching hospital, the medical office building, and the teaching buildings, that realignment had to occur.
Right. UT is paying for that realignment, for the work of the construction of the road itself. I'm hoping that we would not put that on the table, that we would look for city funding to do that. Then 2 buildings that are right adjacent to the campus on the south side are the Health South building and the Medical Examiner's building. The city owns the ground under Health South, and as far as I know, there is no plan for them to move off of that site or out of that facility. But I guess that's always subject to change, and I know there's been discussion going back as much as 2 or 3 years ago about what would happen if Health South were to vacate that property. And then the medical examiner's office is definitely something that's in need of moving. I talked to the guy who's in charge of that over at the county, Danny Hobby, and they are still looking for a place to move to. They haven't identified it yet. And so that may come up in a discussion too. It's just another complicating issue of the moving parts down there. And then you see the Waller Creek Conservancy. You know, that project is coming along very nicely, and there'll probably be some people involved with that conservancy that might have ideas, for example, about things that should happen right there in around Waterloo Park, where the inlet for the tunnel will be located. And then the other players that you see up there. So there are going to be a lot of opinions and a lot of thoughts about what to do, and we're just going to go through the process. Typically these redevelopment projects take a long time. We're going to try to do the best we can on timing. For example, going back to the Red River realignment, I think our interest would be best served if we were able, if the city has funding for that, and in fact that project is going to happen, then I think we would want to try to do that as soon as Seton vacates UMCB for the teaching hospital, so that we can go ahead and plan for the reuse as soon as that realignment gets done. Yes?
With Health South, at one time Brackenridge was providing some services for them, and with when the hospital leaves, then it'll be vacated. And is anybody talking about those services that
Yes.
are being?
Yes. We, on the advice that we got from our attorney, we are not going to have to step in their shoes to do that. Seton is still going to have the obligation to do that, but we will probably be involved in that in one way or another, because I think we will be expected to take over plant operations, you know, where the plant operations building is. We wouldn't necessarily be negotiating with Health South or dealing with them, but it's something that we might not be able to avoid altogether, being involved one way or another in it.
Question over here, please.
Oh, yes.
Regarding the realignment of Red River, I remember when the breezeway, a walkway was constructed between the main building and the parking garage. And my general understanding is that its capacity, height, so forth, took into consideration the traffic count on that old alignment. If we realign Red River, the traffic count is going to skyrocket, and that structure may have to be re-engineered or removed.
Right.
Keep that in mind.
I have that in mind, and I'm supposed to be meeting with the Assistant Director of Transportation, hopefully within a couple of weeks, to walk that site. And they have committed to help us through the city's Public Works Department to sort of do the analysis of where, you know, things are going to have to go and what's going to have to, you know, our question is, how is it going to affect any of the structures that are there in the right of way?
And I think it's also important for us to understand long-term how they intend to use that realignment. There has been discussion that that would be transit-oriented and not traffic, not car traffic. So it's more, you know, buses and mass transit and EMS, you know, emergency vehicles, et cetera. So that'll all be part of the planning. And if I could just add on to what John has said, you know, we're talking about an innovations cluster, which is a particular, you know, concept that's trying to be vetted and evaluated and decide what we want to have here. But that's also in context of a larger visioning that's happening around an area which I think we call it the Eastern Downtown Corridor. So if you think, I don't have a map here, but think about MLK, south to the river, eastern boundary being the access road or I-35, and the western boundary, was that Trinity? Where do the tennis courts are?
Yeah.
Is that Trinity? Yeah.
Trinity.
They're
So
between Trinity and San Jacinto.
Yes, so think, medical district at the top, you've got Waller Conservancy kind of going all the way down to the lake, and then you've got our property south of the new medical district, and then kind of that whole development down, to the lake, if you will, to Lake Austin, so, or Town Lake, excuse me. So part of the discussion in this advisory group is sort of overall visioning of what do you want that whole corridor to look like? If you think about the redevelopment that occurred on, say, the Second Street and that area. So it's a kind of several layers of discussion happening. What are some principles, some guidelines around how we would like that property, or that whole area to kind of look and be utilized by the community. So it's really it's a pretty fun project to be involved in, because it's about what we do with our property and then how it fits into this larger vision for this part of downtown.
Okay. Clark first and then you, Lynn, okay?
It's an exciting project. I'm glad we're part of it. I hope that, we're a good neighbor and kind of fit into the thing. I want to be sure that our mission is not lost in the buzz of an innovation cluster. I mean, to me, our strategic planning project has got to start with our mission and what we really need done from a healthcare standpoint on that property. And I hope that we exercise an independent judgment about what that is and don't let a broader community process kind of indicate to us what that ought to be. And I think there's a danger that could happen if we don't really work hard and soon in terms of what are the healthcare uses that we need to put on our property, because there are going to be all kinds of people who have other things that might happen with our property that would advance their interests in one way or another. And this process that we have become a part of is going to be so big, and there are going to be so many people kind of pushing. If we don't know where we're trying to get, that there's a risk that we will drift in some way that's not consistent with our mission. So to me, job one on this is to really, we got to be a part of what's going on and understand what's going on and try to be a good neighbor and accommodate big things like the innovation cluster, which I hope happens. But we really have got to focus on the healthcare uses that we need on our property and be sure that that's where we're heading, or I fear that we'll get pushed around in some way or drift in some way. And so I just want to kind of get a stake in the ground on that.
Thank you, Clark.
And that, Clark, that's going to be my focus in this project all the way through it. I mean, I think we're going to work very hard to try to collaborate with everybody who's going to be involved in this. And if it fits in, if the use of the property fits in with their priorities, but with our priorities as well, then we'll work hard with them. Otherwise, we'll exercise the priorities of the board. We'll work towards those.
And I think, just to add on to that, I think it's when we determine the use, what is the most appropriate use for our property, we have other partners we need to be talking to about that, like UT. Sure. If we're identifying service gaps, are those service gaps best met on our property or theirs, so that we're maximizing how we use our property? So I think we've got I think about sort of concentric circles. We've got sort of our internal circle and our internal partners, and then we've got this larger community vision that we're just participating in. I'm glad we're in the middle of that and not having other people come to us and tell us what their grand vision is for our property, but they're hearing all along.
I'm glad we're part of it, but I think we need to develop, and I just, I know I'm a broken record, but we went into this whole thing, Lynn was kidding me just a minute ago, mental health, outpatient specialty care, women's services, and of course, I think cancer is a part of outpatient specialty care. I'm not going to let go of that. I want to be sure that we have a vision for how we're going to accomplish that, and we have a very valuable resource in that land. And I don't want to turn loose of that land until we see the vision that the team develops for our priorities, you know, be real. Doesn't necessarily have to get done. We won't be able to do it all by ourselves, but I mean, to me,
Right.
those two connect.
Yeah, I think the value for us right now is to be able to, from the beginning, articulate what our interests are.
Right.
And have people, have continued to articulate what those interests are, so that we don't end up in the position that you just described.
It's sort of like our vision for academic medicine too, you know, we had that
Yeah,
written,
we
and that
said,
was our
yeah.
blue point. The question
Yeah.
I have is simple, because I don't quite understand. All this cluster, all these guys, all this help, is it just to help figure out what to do for our property on that?
No.
that block?
No.
I know, you talked about that whole thing going down south, but
And it's not targeted on our property. I don't want anybody to walk away from this thinking that they're targeting our property.
then what is their picture of where they want to work on? I mean, you have all this vision.
They don't know yet.
This is-
That's why we're gonna have to do this work here, and ultimately, this advisory group will come forward with a set of recommendations that will really go out to all of the people who have a stake in what's going on down there and what Trish described as that eastern
So
downtown
the
corridor.
down there is their bigger geographical corridor,
Yeah.
or that's their target area, the down there, that big area.
Yes.
Right, okay.
So when you look at the land, you've got the UT land, you've got our land, and then you've got the state doing an analysis right now of sort of what excess real estate they might have that they will not need for state purposes in the Capitol complex. And if, for example, they don't need those parking garages between Trinity and San Jacinto, then maybe some of that becomes available for this.
Right.
But if it doesn't become available for this, then there's going to be a shortage of real estate. And there are going to be people looking at this property and saying, why don't we do something else with it besides
But they're
healthcare?
also,
And it may well be we can accomplish our priorities on, you know, on some other piece of real estate. I'm not saying
Yeah,
that we can't, but I just, before we give up a chunk of land to something that's not healthcare, I want to be sure that our healthcare vision is firm and that if we need our land, we're going to use it for our mission. That's all.
absolutely.
Other comments?
Since it's late, no, but I'll echo your sentiments. Not here. You have my full support. That's all I have to say.
Thank you.
Thank you.
Two other things very quickly, just to let you know, we've got an appraisal of the property going on right now. Hopefully, we'll get some results on that probably in December. We have an RFP for a planning consultant to help us through that reuse planning process. That's out on the street now, and those proposals are due in January the 2nd.
Okay. Thank you, John. Okay, number 11, we are going to go into executive session, but I will tell you that it
Well,
will
we've got-
be brief. No? What?
Wait, Sarah's got an open session.
Part first?
And then a closed.
Okay,
Yeah.
okay, so we'll do the open first, and then we're going to go into executive session. Executive session is brief, though.
Very brief.
Okay. 11, discuss and take appropriate action on the 1115 Medicaid waiver, delivery system reform incentive payment projects, the Community Care Collaborative, including healthcare delivery arrangements and other interrelated community partnerships.
Good evening. My name is Sarah Cook. I'm the Medicaid Waiver Director, and I have a couple things to talk to you about tonight. They're both interrelated, and they both relate back to so much of what you've heard earlier tonight that I hope that this will be a nice capstone for our evening, and I hope a short one as well. So I have two things to talk to you about tonight. The first is about the RFA process that we're about to launch on, embark upon for these DY3 DSRIP contracts. And then the second that I'm going to be asking for action on is an approval of the DY3 DSRIP implementation contract template. You received that late last night after it was approved by the CCC board, and so we're bringing it to you. So again, we're just learning about the RFA process and then approving that contract template. And I think it's interesting, we're going to familiarize ourselves with
with the work that we're going to be doing to identify the key partners that Trish alluded to earlier, who are actually going to be meeting those metrics and milestones that are embodied in our DSRIP projects. You know, one thing that I wanted to talk about first is that we're really balancing attention here between this board's stated objectives and, of course, the CCC staff objectives and the board objectives there, too, of transparency and opportunity to partake in these DSRIP projects. And we're balancing that against the urgency with which we really need to start undertaking these projects so that we can meet those milestones and metrics, and the need for achievement in all of these projects. So that's a tension that we've been living with, but I think we've come up with an RFA process that I feel answers those. Just to remind you of the activity to date, back in August of this summer, we reviewed all of the CCC projects at a really large stakeholder meeting, over 20 stakeholder groups, and I think 50-odd people were represented at that meeting. Following that meeting, we requested for and received statement of interest forms from all attending folks and those who weren't able to attend that just said, you know, we're interested in performing X, Y, and Z DSRIP projects, and this is why we think would be a good fit. So we did have sort of a general solicitation of information from folks that we made note was definitely not part of a formal process, and that the more formal process would be coming. But we do have a sense of who in the community is interested in performing these DSRIP projects. And it's a large number of people. And it's both clinical organizations and support service organizations. So what we're proposing is this, that we release an RFA for those 5 projects that are on the left, and we'll release that in short order. You'll see the timeline soon. That we release in another round of request for application, RFA, 2 projects that have yet to be approved, or rather modified by the state and federal governments. So we feel that we're able to act or receive solicitations on those first 5 projects. The mobile clinics project and the Centering Pregnancy project, well, we're going to ask for a substantial modification to the mobile clinic project in our modification period, which is upcoming. And Centering Pregnancy has yet to be submitted, so that's not a project that's been approved yet, and therefore isn't available. For the 4 projects on the bottom left, we propose that we carry over our DY2 contractors, those agency partners and community provider partners who helped us develop some of the materials required for our DY2 submission. And then these 4 projects on the right are actually going to be incorporated into all contracts. We're asking that any contractors are going to work with us to implement the chronic disease protocols, PCMH standards, and certification as desired and requested, participate in our disease management registry, and of course partake in the entire system navigation programs. And all told, those add up to our 15 DSRIP projects that the CCC is providing. The RFA document that we've developed outlines the philosophy of the CCC and our DSRIP goals. And it outlines the payments that we anticipate being able to make through this contracts. We pay for infrastructure, so any required investments in technology and people that are upfront. Process, we want to ensure that our providers feel comfortable allowing their staff to participate at the required learning collaborative meetings that you've heard of, our work groups for the region, PCMH training, for example. So we're going to contract with providers to pay them for their providers' time to attend those meetings, excuse me. And then this is where some of the shared risk that we talked about takes place. We're going to be contracting for payments on encounter or patient milestones. So let's say embodied in our disease management registry project this year, we need to enter 3,000 people into the registry. So we will tell providers that they will receive a payment when those 3,000 people have been entered into the registry. And of course, they will not receive that total payment if that 3,000 number isn't met. So
Dr. Wilson?
Pardon?
3,000 systemically?
Yes. But, and again, that's just in DY3. That number grows in DY4 and 5, but that's one way that we anticipate working with our providers to ensure that our outcomes are met. Because remember, we don't get paid as the CCC if those 3,000 folks aren't entered.
So how do you share or allocate the obligation among the various providers, given their different clinic configurations and patient contact?
What we anticipate receiving in the applications that providers send to us is that a commitment to enter 2,000 patients, let's say, so that would get a slice and the others would receive it. We want to ensure that our providers get used to providing frequent reports, so we'll pay for monthly reporting. And then, though I don't think this is in place so much for DY3, But we do talk about the potential for payments for outcomes if people achieve really good quality outcomes or exceed all of their performance milestones and metrics, there may be payments available for that. The RFA document is also going to include a budget template so that our providers will be able to understand exactly what we're looking for in their expense estimates, and we're going to require a budget narrative. Applicants for these DY3 implementation contracts must have a Texas provider identifier. And in an email that we're going to send out to all those folks who attended that August meeting, for example, we're going to make note of this fact, and we're also going to let them know that we encourage those who do not have a TPI to partner with an eligible organization to support the performance of these district projects in DY3. We're going to receive site-by-site applications back from providers so that, for example, Community Care would propose to us the project being implemented at North Central in one application packet, also at East in another application project, so that we, when we're evaluating, can choose the best mix of providers and geographic locations in which these projects should be performed. And a lesson learned from Seton is that we're going to need to know folks' project management approach. And as you heard, we have our own here at the CCC, but we're really going to be relying on our contracted providers to have a sense of how they're going to manage these projects, how they'll mitigate risk, how they'll disseminate important information. We need to know that that thinking is underway and actually has gelled by the time they apply for the projects. Can't happen midstream. Again, this line item budget with narrative. We also want to know the impact of, let's say, additional encounters on any CCC contracts. So if a contracting provider proposes to see an additional 2,000 patients in the extended hours digital projects, we're going to need to know what financial impact that will have on its contracts with the CCC that it holds currently. And then we're going to ask that the providers review any subcontractors with the CCC, and we encourage utilization of hubs there. We have a pretty, this was the very aggressive timeline that we've now moved to be pretty aggressive. We'd like to release this, so discount this, I'm sorry about this. We're going to try to release this RFA next week. We'll ask providers to give us any questions on the 2nd of December. We'll reply to them by the 9th of December, and then they are going to submit their awards to us by December 16th, their applications to us, by December 16th. The CCC staff and others on the evaluation committee will take time over the Christmas holidays to read this, and then we'll let folks know by January, the very beginning of January, that we'd like to enter into contract, and that we expect these contracts to be ready by January 31st. So we're really moving on this, but boy, we have a lot of work to do. We were so busy we couldn't update the slide, for example.
Good one.
If you have questions or comments on that, but I do want to let you know that in the RFA packet, we're going to be including, as I said, that budget template, that line item that we want them to fill out, and we're also going to be attaching to it the sample contract, and we hope that this will familiarize our providers with what's coming. And then, of course, we can get a head start on those budget negotiations that we expect to take place and be completed within 4 weeks in January. And so it's on this template that you received yesterday that we would like you to approve it. And just to let you know what's contained in it, I think it's pretty basic stuff. There's the standard recitals, the description of responsibilities. There's notice that we expect contractors to participate in our work groups and our learning collaboratives. It describes access to records, reporting requirements, again, pretty frequent reports, compliance with the protocols that are going to be developed, and those 3 other infrastructure projects. The payment structure that we reviewed, eligibility verification. We just need to know that these folks are going to be district project eligible and accountable. And then standard around the term of the contract, termination, and miscellaneous terms and conditions. We do want to share that with our providers soon, so we'd like to ask for your approval for it. And of course, we're going to be returning to our boards with contracts greater than $100,000 or with our affiliates, so we just want to let you know what's coming.
Okay. Madam Chair, with that in mind, I move that the board approve the demonstration year 3 Community Care Collaborative Delivery System Reform Incentive Payment, DSRIP, project implementation contract template as presented by staff. And as noted, the CCC board also voted that any substantive changes to the template be brought back to
their board for approval. Okay.
Second.
Okay, a
With
motion
an
and a second.
observation.
Discussion.
Yes.
Yes, go ahead.
I did not see an indemnity provision in here. Why
Pardon?
not? Indemnity. Indemnity and hold
We
harmless.
discuss it in the RFA, don't we? Noted if.
Yeah, I think it's in there. It's under 10A on page 5 of 8. There's an indemnification provision.
5,
On page 5 of
10A,
8, under
okay.
10A.
In bold.
Okay, great, thanks. Then the, please help me with this. On page 2 of 8, the general description of CCC/provider project responsibilities, bullets 3 and 2 fall under the scope of service, as I recall. So how do these dovetail?
Establishing baselines.
Yes. Under their project, the scope of their project management responsibilities.
Sure, they had done much of that for DY2 for a number of these projects that are implemented in DY3.
Yes, but we're asking the contractors to formulate these measures.
No, I'm sorry, under 1A?
Yes.
We are outlining the general description of both the CCC and the provider. So under 1A, we're identifying what the CCC will do, and under B, we describe what the provider will do.
Thank you.
That's the intent of how that's
Okay.
structured.
Sorry, I misunderstood.
Ms. Tom?
Is this just for outpatient services, or is this for the hospital too?
Outpatient.
Just for outpatient, the hospital won't have to comply with it. The other thing, have y'all talked to the other providers, not community care, but the other providers about how, I mean, this seems a little bit complicated to me, but maybe for lawyers.
Sure, and we're, as I said, I think that I plan to send an email to, again, that broad group tomorrow, and then we're going to have smaller one-on-one meetings. I think we already have one arranged with Peoples, or one to be scheduled with Peoples to review this, and Lone Star is in the works to sit down, walk through this, again, familiarize them with the terms of the contract, and we'll be working our way through our providers to familiarize them with all this in the hopes that we can move swiftly come January.
One other. Are you finished, Dr. Cooper?
Yeah.
The force majeure clause. Did we consider a provision based on loss of funding? Because many of our clinics have grant funding. If they lose a grant, they may not be able to provide the contracted services.
That would be a change from our typical language. If that's the will of the board, then we can make that change.
I guess I just want to understand why we would do that if you're already paying them for these services.
Well, I'm throwing it out for consideration. Okay. I'm not suggesting that it has to be there.
I would also propose that there's a termination provision in here, and you can terminate without cause with, I think it's 30 days written notice. And so if that were to happen, I think there's an opportunity in a process for them to get out if they had to.
Okay. That's my issue. Thank you. You've answered it.
Certainly.
Okay. Anybody else? Okay, ready for a vote? Okay, all in favor signify by saying aye. Aye. Any opposed? Okay, we're good to go. Okay, we're going to go into executive session. I announce that the board is convening in closed session to discuss agenda item 11 under section 551.071 of the Texas Government Code, consultation with attorney in section 551.085 of the Texas Government Code, deliberation of governing board of certain providers of health care services. Okay. Let's do Okay, it's 9:37 p.m. We are back from executive session where we took up agenda item number 11. There is no further discussion or action to be taken on that item. So now we're at number 12, which is to confirm the next regular board meeting date, time, and location. I'll be doing that, but we also need to schedule a special called meeting, and I'll do that after I confirm the next regular board meeting. Okay, there we go. The next regularly scheduled meeting of the Central Health Board of Managers is on Wednesday, December 11th, 2013 at 11 a.m. Okay, 11 a.m. That's a change from our normal meetings, but this is our December meeting, and we've always had our December meeting at 11 a.m. Right here at the Central Health Administrative Offices, 1111 East Cesar Chavez. Okay, now we need to schedule a special meeting, and I need for everyone to look at their calendars and see if you are available for a special meeting on Wednesday, December 18th at 5:30 p.m. to discuss waiver-related matters. Yes, 1, 2, 3, 4, 5. I can 6. Okay, good. That's a quorum. That's a quorum. So with that, I need a motion for that.
So I move that we hold a special call meeting on December 18th at 5:30.
To discuss waiver-related matters.
To discuss waiver-related matters.
Okay, thank you. Can I have a second?
Second.
Okay, any discussion on that? All in favor signify by saying aye.
Aye.
Okay, and we've come to the end of our agenda. Oh, no, one thing I forgot. Yes, I just remembered right now. Hold on, give me a second. On number 11, on the motion, Dr. Coopwood needed to abstain from voting on that. So for the record, please, if we could show that Dr. Coopwood did abstain for number 11. Okay? Okay, now with that.
I move we adjourn.
Okay, can I have a second?
Second.
All in favor signify by saying aye.
Aye.
Okay, we're done. Thank y'all.